Everybody had a good lunch. Thanks, Bob and Brad. Had a couple of those chocolate chip and oatmeal cookies. They were pretty good. So Bob asked me to chat about SI joint dysfunction. Any of y'all see that by a show of hands in any of your athletes? So, yeah, and so we're going to cover the SI joint about as much as we can in 20 minutes. So I'm going to try and give you a little synopsis of the literature that I think when you have bunches of athletes coming in right after class and somebody points to their SI joint and says it hurts, kind of something that you can screen out and determine, is that the lumbar spine, is it the SI joint, and maybe what are some concepts that should guide our treatment or management of it. And so I don't have any financial relationships to disclose. This just came out in the British Journal of Sports Medicine. So this isn't in your slides as what was printed out for you, but it's an editorial in this month's edition of British Journal of Sports Medicine. And if you don't read it, I'd highly suggest you just following it or following Peter B. O'Sullivan on Twitter and Karim Khan, their editor. But it's a one-page editorial that just discusses why are athletes treated so different than our current clinical practice guidelines suggest with regards to low back pain. And one thing they really get at is that a lot of people end up getting x-rays and in particular MRIs. And we know that the more you scan a patient, the worse their outcomes. So the more money you spend on getting imaging, the worse their outcomes, in particular with low back pain. Because what it does is it elevates their fear. And in relation to the SI joint, it pretty much has no utility. So, or at least none that's been determined thus far. And so they say that our management of low back pain is in sports seems to be to reflect a schizophrenic mixture of minimization, so rest and scanning, intensive therapies, passive treatments, and stabilization exercises, and early use of aggressive treatments such as spinal injections or surgery. So just kind of big picture, the words we use matter and highly influence outcomes. Hey, Kale, will you? Oh, got it. So we're going to talk about the anatomy and biomechanics, the prevalence, pathophysiology, some physical exam procedures, and touch a bit on how do we treat it. And so anatomy and biomechanics, the SI joint is a big force transfer mechanism. So it takes the forces from your feet that pass through your hip and into your spine and efficiently transfer those. And it's an odd-shaped joint. It's said to be a bit auricular in nature. So it's this red shaded area, and it's got this propeller type look to it, and it's thought to change and become much more arthritic in middle age. So mobile when you're a kid, mobile around pregnancy, and then stiffens from that point on. So diarthrodial joint, well stabilized by ligamentous constraints, and remainder of stability is provided by muscular corsets. And so when I say the ligamentous constraints are effective, it takes a lot to actually dislocate an SI joint. So you basically need a high force mechanism like a severe car accident. And what will happen then is they'll put a couple of pins between the iliac wing and the sacrum. And nowadays it's being proposed more as a treatment for SI joint dysfunction, which I haven't seen anything with regards to the outcomes on it. But in general, we don't fuse hips, so I'm not sure we want to fuse SI joints either. Doesn't seem very logical. So we've got a bunch of ligaments, and in particular during palpation, these ligaments here, the long dorsal ligament and sacrotuberous ligament here line up well with the force transfer coming from the leg. And so it's said that the sacrotuberous ligament aligns really well with the biceps femoris as far as a force transfer goes. But those posterior ligaments can become tender. So usually your patient will point to their SI joint or PSIS, and if you palpate their long dorsal ligament, there's some evidence to support that is suggests an SI joint dysfunction. These are the ligaments. So this interosseous ligament is super strong. It's also a bit of a crooked joint, like we talked about earlier. And so just all what this means is it's meant to be a pressure relief valve. It's meant to transfer forces, and it's not something that's meant to have large amounts of movement. Another thing to think about is how your hip socket, which isn't shown here, right, but is about in here with regards to the plane of the body, kind of beneath the lumbar spine. But if you can think about that force is passing around your pelvic ring and then up into your spine. And so if we want to take an older person who has osteoporosis of their spine and help them change that, what we would do is a lot of leg lift, leg exercises that transfer lots of load across it, and that will change the bone density of the lumbar spine. And so with that in mind, things that pass from the floor go up and into the SI joint, which is going to matter in your female young cross-country runners that have hip drop and a lot of bad biomechanics. So speaking of the hips and hip drop, so your glutes are your big supinators, right? They help with external rotation. They keep your knees out, prevent the dynamic knee valgus we see in a lot of our lower extremity athletes. But it's also exactly in line with the lats. So that's one of the slings. So when we think about the SI joint and how we're going to provide stability, or just how we're going to have some biomechanical efficiency, we're thinking of ways that we can work in diagonal patterns. And one way I like to challenge healthy folks or people progressing out of their SI joint dysfunction is to have them do a push-up with dumbbells in their hands, and then they add a row. And so you've got, when you pull your hand up off the ground, so you're here and you get down, push up, and then when you pull your hand up off the ground, you're causing a diagonal load. And so you're getting a lot of force transfer across that joint, and that helps facilitate that stability. So if you want to really feel your obliques kick in, trying something like that is great. And you also have your anterior sling with your adductors and your internal obliques and your abdominal fascia. And once again, when you walk, as your leg goes behind you and as your leg goes in front of you, you're going to get micro movement of the SI joint. But if you ever have somebody x-ray your pelvis and say, oh, well, your ASIS is, sorry about that, your ASIS, whoa. Your ASIS is off. Don't believe them. Okay, there's no good effective way to measure what your iliac crests are doing on imaging, because you lay a little bit off each time. You clench one of your butt cheeks because you're cold or something like that. It's going to throw the imaging off. But it's a great way to scare the hell out of people and get at least poor outcomes or lots of visits from your athlete. And so this is a look at, I'm sure y'all see some of these different postures in the training room, right? Y'all see linemen walk in and they're waddling their butt back and forth, right? And so their spondylolisthesis is about to happen at any given moment here. And then you have maybe your cross-country runners that don't have a butt at all, and they kind of get pulled along by their hamstrings. So neither one of those are real effective, and neither one of those are particularly good on your SI joint, but both of those are reasons to also screen the lumbar spine before you move down to the SI joint. And then seated postures like this. So all of this plays with your ilium, and all of this is going to put different stresses. across your SI joint. And then it's going to wiggle you when you walk, and that's normal, and we want some movement. And then from a biomechanical standpoint, this is what our abs are meant to do, right? Our muscles and our fascia are meant to produce stiffness when you're lifting heavy loads, which is why you hold your breath before you do an Olympic lift. Your blood pressure goes through the roof, but your spinal stability, instead of being the width of your spinal column, becomes the width of your body by holding your breath. And you transfer energy. So throwing a baseball, your spine has to be a little bit like a slinky, right? You need your pelvis, your hips to dissociate from what your shoulders are doing to be able to generate velocity. And then we're also trying to recover elastic energy. And then this is pretty cool. If we think about our abs, there's some very good relationship to what our meniscus does. So the bottom right here, we've got our meniscus. And we're taking a vertical force, so the weight of our body landing down under our heel or cutting or jumping. And we've got this triangular spacer here, our meniscus. And with a downward force, the meniscus wants to extrude out, wants to literally pop out of the joint. But because it's anchored by the roots here, that force pushing out becomes a what we call hoop stress. So it takes a vertical force and makes it spread out efficiently, okay? Well, that's the same thing that our abs do. So our abs, we've got the strap muscles in the front, the rectus, and we've got the strap muscles in the back, your erectors. So those are your vertical struts. Then you have your diagonal struts, right? Your internal and external obliques. And then you have a completely horizontal muscle, the transverse abdominis. So you've got something going in every direction to support your rib cage to your pelvis. And so what we do is we take vertical loads and we transform them into diagonal loads that can be dispersed, like between the lats and the glutes. So anyway, so I thought that was pretty cool, kind of as I was reading through the literature, thinking about how our spine and the meniscus have some real commonalities. And then just notice how much fascia is here. So if we think of this fascia to some degree like a tendon, not quite as good as the Achilles, but it's meant to be able to store energy. And so we have to be able to engage that with our glutes and our lats. On the front side, if we think about our rectus, it's like a hamstring with little spacers in it. But these spacers tell you that this muscle isn't meant to produce a crunching motion, right? If it was meant to create movement, it would be long, just like a hamstring, and not have these little intermuscular tendons or septums in it. What it's designed to do is keep you from getting pushed backwards like this. So it's literally an anti-extension muscle. So when somebody hits you or you hit somebody else, you don't get a big energy leak. So if I go to hit somebody, the force, like say I bench 500 pounds, which I definitely don't. But say I do, and I want to go hit somebody with that force, and my limiting factor is my abs, and I just bend backwards, I'm only imparting half of that because I've leaked out through my kinetic chain because my abs are my limiting factor. So the rectus is meant to keep you from getting pushed backwards, probably only if you're a gymnast and a few other sports does this actually help you create movement. Whoa, sorry about that. And then the lats I've mentioned a few times, but they're a natural back brace. So the way they invest into this thoracolumbar fascia, when you're deadlifting, as this guy is doing here, you're taught to put squeeze your shoulder blades down and back and engage your lats, and that engages the fascia. And it's easy to see on this guy and hard to see on most normals. But working lats is useful as you try and stabilize the SI joint. And this is just a simple look at the force transfer mechanism, the vectors being passed around the pubic ring through the SI joint into the lumbar spine and vice versa. Sorry, I'm trying to figure out the exact magic touch here. There we go. All right, so there's a couple different ways to provide stability. So there's the thought of the form closure, and the form closure has a lot to do with that propeller shape and the odd auricular shape of the SI joint. The other way is by force closure, which is like we've talked about the lats and the glutes, the transverse abdominis, and these diagonal patterns. So prevalence and pathomechanics. So sports is risky. Some risks are just funny and others are more serious. The nice thing about the SI joint is while it can seriously impair function, it's not serious as in it's not going to progress and turn into something that's going to give you drop foot or anything like that. All right, more risks of back pain. So it's prevalent. I know y'all see it in the training room. I know when I help out at U of H, there's always a number of folks that are dealing with back pain or SI joint pain of some type. So it's really common during pregnancy, and most of the time it resolves, but there's a lingering 8 to 15% that's thought to not resolve. And then as far as athletes, they're relatively unstudied, but athletes that are thought to be at risk are those with asymmetrical loads. So baseball players, golfers, running is a repeated single leg activity, so that's asymmetrical. And there's some idea that younger athletes, those who are going through growth spurts, may be a little more at risk because their lever arms are getting longer and their strength doesn't catch up for a while, so there's that delay. I was trying to teach my 7-year-old how to squat. My 2-year-old does a beautiful squat, and my 4-year-old is okay, and my 7-year-old about to turn 8 is terrible. I can't figure out what happened, but she's just getting taller and taller, and her strength doesn't match. She can run fine, but you ask her to squat, and she's literally all over the place, and the motor pattern changes with each repetition. So there's not a lot to coach there. She's just got to be a kid and play around. But for whatever reason, at 8 or 7, you can take your kid into the gym at the Y, and you don't have to leave him in the daycare. And so I promised she could go, and so she spent a lot of time on the bike because otherwise I couldn't do anything. So anyway, so pathomechanics, we've kind of hit this quite a bit. Physical exam. So what physical exam test should we do? Any suggestions? Suggestions? Any favorites? All right, so the first thing is if they point to that area highlighted in the rectangle, they might have SI joint pain, right? So between the PSIS and the ischial tube or the sacrotuberous ligament. All right, so generally speaking, it stays above the knee as far as the pain referral pattern. Ooh. So these are a couple of mechanisms of injury, right? Tiger Woods, among other injuries, that extension, right? Hyperextension and rotation under a load with a lot of speed. It's not healthy for the back. I've seen a good number of volleyball players who struggle to arch. They don't have the eccentric strength of their abs to truly arch back and then go into a pike. Not to mention that, but the landing loads that they have. And then in our biomechanics lab, we see a lot of people who run and their feet are swinging out to the side, which means their knees are coming in. And anytime you land in that position, your pelvis is going to flip-flop all over the place. So when the knee comes in, so you tear your ACL if you're in a high-speed sport, and if you're in a jogging thing, then the opposite side pelvis is gonna drop, and that's gonna cause pain in your hip or your SI joint or your back. So more about history and complaints. Usually it's with movement and transitional movements in particular, going up and down stairs, jumping, running, playing sports. So we assume it's the back until proven otherwise, and then we can assume it's the hip until proven otherwise. We rule out the joint above and below it, and then we get to the SI joint, and then we simply work through provocation tests. There's 4 of them. Then we palpate the area, and then we can do what's called an active straight leg raise test and see if they need stability. All right, so distraction, thigh thrust, compression. You can use Faber's as well and Gainsland's, and so I think I have pictures on the next slide. So the big hitters are here, the distraction top left and thigh thrust top right. If those 2 are negative, you probably don't have an SI joint issue. The other 3 are part of a cluster that can help you define if it's an SI joint issue. And then your active straight leg raise test. So you've all seen and had your athletes do a straight leg raise. And so what you can do is you can do a straight leg raise, see if it hurts the SI joint. And then what you do is you compress their pelvis, provide them some artificial stability, and then have them lift the leg again and see if that takes the pain away. And if it does, then you think, all right, well, maybe I can stabilize it. And technically, being that you've passively stabilized it, so maybe an SI belt might help. I'd avoid those if you can. And then what you can try is this test where you essentially have them do a straight leg raise, but you're resisting, if I'm lifting my left leg, you're resisting the contralateral shoulder. And if that takes the pain away, then you know they're forced, if they actively create force across those diagonals, that their SI joint doesn't hurt. And so that lets you know that you can help them actively stabilize to solve this problem. So treatment. All right, so manipulation. Normally I'll start and manipulate the thoracic spine, knowing that a lot of people are sitting at desks and have forward head posture. Then I showed this manipulation on the bottom right in lab. And then this is a great article. If you Google Van Tolder, I can get it to Bob, but basically there's a phased approach to rehab. And so you're trying to figure out their lordosis, so get them into a neutral spine, get him to load transfer, getting him in good alignment and standing, and then single leg standing, and then getting after their aggravating postures or their sport. So phase 1, you might do breathing exercises, abdominal drawing in maneuver. So that's called crocodile breathing. There's some good videos on how to do that online. Holding your breath, right, provides more stability, but you don't get to choose when you hold your breath in sports. You can do planking and start against the wall and then progress to horizontal. And noticing how runners need to lock in the rib cage, that picture on the far left, okay? And then McGill crunch, side plank, and bird dogs are great places to start. And then let me wrap up here. Hip hinging, and then you get into fun stuff like the push-up row. Most of your athletes aren't going to be getting to this point outside of maybe the physio ball rollout. Having them do RDLs, but doing an airplane where they open and close. Working on squatting. And then getting counter rotation, so Palloff press. Those of you who aren't familiar with that, that's very fun and easy to teach. And then getting into single leg activities and double limb activities, and then developing power and speed. And then playing tug of war with towels is a ton of fun. So they don't know when you're going to pull on the towel, and they try and keep their feet locked into that spot. And then working on medicine ball throws and things like this. So how do you get from low-level activity to activities that more mimic their issues? So anyway, these are a couple other articles I highly recommend. Pain Science helps you pick words because they matter with your patients, and it's all about athletes and low back pain. And then Harvey et al., they're from Texas Children's, wrote about lumbar injuries in the pediatric and adolescent pain population. So anyway, I appreciate your time, and hope you have a good conference today and tomorrow. So what that means is if an athlete runs out of insurance, we have a cash-based rate. We basically try to group athletes.
Can y'all hear me now? Everybody hear me? Okay. Good afternoon. Again, my name's Jamie. I feel like I'm really loud. No? Okay. And like Brian said, I run the Return to Sport program at the Memorial City location. And let's see if I can do this. I am a Memorial Hermann employee. So there's my disclosure. All right, and today I wanted to talk about the team approach to returning an athlete to sport. And I kind of put down all of the people that might be involved in an athlete's rehabilitation. But today I kind of wanted to focus on the relationship between the athletic trainer and the physical therapist or the sports medicine clinic. Now, all of these people are going to be involved in the return to play for an athlete. Now, sometimes an athlete may not have, a dietitian involved or the school nurse, but they're going to have a lot of people involved. And I think it's very important that we all get on the same page in order to return that athlete back to, and I didn't even press that. Did that do that on purpose? So, and then what I did here was kind of jot down, what do we need in a return to play program? What do we need? We need the correct stresses on the healing tissues, neuromuscular training, progressive strengthening, development of endurance, development of power and agility, sport-specific training. And then hopefully during the time that all of these are going on, the athlete is going to get support and encouragement. And they're also going to develop a relationship with their physical therapist and their athletic trainer. All of these are not going to come probably from one single source. Some of them are going to come from multiple sources, but hopefully the athlete is going to get all of these from somewhere. And that's where I think that the team approach is going to come in. And what can a sports medicine clinic contribute? And I'm specifically talking to the high school athletic trainer here. Well, the sports medicine clinic is going to have a one-on-one or small group kind of setting. They may have some equipment that is specialized that the high schools can't afford or some of the sports clubs can't afford. And they're also going to have some clinical collaboration, like, for instance, having Brian in the clinic who does really well with backs. If I have an athlete with an ACL, but they have a little back issue coming up, I can grab Brian really quickly and talk to him about that. We have summer hours, and hopefully our high school athletic trainers are getting some well-deserved time off during the summer. And we also have multiple disciplines. Working in an Ironman sports medicine clinic, I'm fortunate to have a dietitian at my disposal. I have a strength and conditioning coach at my disposal. If I have certain questions about an athlete that I'm working with. Okay. So I wanted to talk today about a team approach, and I think a big part of that obviously is communication. And this quote, "The single biggest problem in communication is the illusion that has taken place." I'm sure that we can all relate to that on so many levels. Athlete to trainer, trainer to coach, however you want to work it, marriage, I don't know, but there's definitely a problem. Communication is kind of one of those things where even if you think it happened, it's even good to follow up. So my first experience working as an athletic trainer was with a contract company for NASA, and this is me actually right here in the EVA suit. And I'm in space, and these are Martians. I'm just kidding. Just kidding. This is actually me, and I'm working with what's called a PGT, and this is a pistol grip tool. I'm in the EVA suit, and I don't know if anybody's seen The Martian, but that is not how you get in the EVA suit. It is much more complicated than that. And I'm working in the NBL lab, the neutral buoyancy lab, and what I'm doing is basically I went into the EVA suit to learn about the stresses on the body in the suit so that I could better train the astronauts for their training. And for, we also did a lot of injury prevention in the suit. But all this to say that when I first got to NASA, they didn't know what an athletic trainer was. They didn't know what to do with me quite. They were kind of, we were all unsure of each other, myself and the flight surgeons. But once we kind of got to know each other and kind of got settled, they invited me to come to their Monday morning meeting. And they had the flight surgeons, they would all get together on Monday mornings and discuss astronaut cases. And so I got to come in at the first part of the meeting, and I would discuss all of the musculoskeletal injuries that I was caring for, the treatments, and we would talk about the treatment plan, and we would talk about what, is it best to hold them out of certain types of training, and it was a very good venue for us to bounce ideas off of each other. And when that was working, it went really well. The outcomes were good, but it didn't always work that way. Things happened. Astronaut may have gone to an outside source that we didn't know about. I also attended specialist appointments with the astronaut in order to come back and report that to the flight surgeon. So if they went to see an orthopedic surgeon, I would go with them and then come back and say, well, the surgeon said this, this, and this. So yeah, when it worked, it worked. So when I went to the orthopedic clinic at Texas Children's, and all of the high school athletic trainers are going to get a kick out of this, I was shocked that you guys didn't come to your athletes' appointments. I mean, I was like, oh my gosh, they can't come. But little did I know the amount of athletes and the amount of stresses that you guys have. And this is my perception of a high school athletic trainer, and pretty much how I would handle it if I was one. So I feel like this is you guys right here. Where's my little pointer? And then this is all the stuff that is coming at you. So what I realized when I was there was that I wanted to reach out to the other athletic trainers and let them know their athlete was here and what the surgeon said, because I knew you couldn't come. So there was already a plan in place for this. They already had a way to do that. So I just kind of picked it up, and every single athlete that came through the door that I knew about, I tried to call their trainer, get permission and call the trainer, or email or send something or whatever. And then when I went to Memorial Hermann and in the sports medicine and rehab clinic, I wanted to continue that. So slides here. There was like 3 main reasons why I felt like this was kind of important in the sports medicine clinic. One of them was non-compliance. Like, you've got your kids that weren't coming in. So they weren't coming into their physical therapy visits, and the physical therapist would mention to me, hey, I haven't seen so-and-so in a long time. Can you call their trainer? So I would call the trainer, and the trainer was like, no, I haven't seen him either. So then, one of the 2 of us is trying to track them down. Another reason would be overtraining. We had a lot of kids that were, they were higher end rehab. They were going to, team workouts, time with their athletic trainer, physical therapy visits. And it was important for us to try to communicate so that we all weren't doing the same things, and that they were getting the things that they needed in order, and they were not overtraining. It may be at the time where we thought it was really important for them to go to the team workouts. Well, what are you doing at your team workouts? We're not going to repeat that over here. Call the coach, call the trainer, and see what they're doing. Send them something that they can do in the team workouts so that they can, not do something that would cause re-injury. And also there's that return to play transition where they're able to do some drills, but not all the drills. And so I thought it was real important to communicate, with the athletic trainer, they can do this and this, but they can't do that. And, that way the trainer can kind of, let the coach know. And also, in my program, being the return to play program, I felt it was really important for me to communicate with the physical therapist that was referring them over to me, or the athletic trainer that was referring them over to me. And then I'm also communicating back out to that athletic trainer where they're going next. So, which was easy because most of the physical therapists were in my, in my clinic. So I was able to communicate with them. And also I had probably worked with that kid while they were in there, and then they easily trans over to return to play. And then I could communicate that out to the athletic trainer in the high school. So, and then I put this up here. I kind of have seen the 2 extremes. There's the kid, like I said, that was overtraining. They were doing everything. They were trying to get back on the field as fast as they could. They were really motivated. And then you got this kid that needed a shark behind them in order for them to have any kind of work going on. They weren't getting in to do the stuff that they should be doing. And we really needed to communicate with their athletic trainer to make sure that they were coming in and doing some extra work outside of physical therapy. So, and I've said some specific examples that I've tried to do. I've tried doing reports where I've sent something, where's my little thing, where I've sent some, stuff with contraindications, what exercise they're doing in the clinic, what they can do in the training room to supplement what they've been doing in the clinic. I've also communicated through email and phone calls. I've gone to physician appointments with some of these athletes and then reported back to the athletic trainer. I really thought it was important for me to connect the physical therapist with the athletic trainer. Sometimes the physical therapist is, super busy during the day and they don't even have time to call. But if I would put an email out and CC them on it to the athletic trainer, they could maybe email that way. And then at Memorial Hermann, we have athletic trainers that are outreach, which is great because I can also communicate through them that way. So, in summary, I like this quote. I love Walt Disney, and I like this quote. Is the way to get started is to quit talking and begin doing. And I don't think we have it perfect as far as our communication and our teamwork, but I want it to be good. I want it to be. I think I think the outcomes are going to be better for our athletes, and and that's why we're all doing this. We want the outcomes to be good. We want to work together. We want to make sure that these kids are not getting re-injured. They're finishing their rehab. They're getting to that point where they're at return to play. They can go back with confidence. And it's a work in progress, but I think we've started it, basically. And thank you very much. Oh, I guess I should have done a question. Sorry. Does anyone have any questions? No. Yeah.
You're supposed to be.
Huh?
Ryan was supposed to be here.
Oh, I'm sorry.
Put your coat on. That's, there we go. The clicker's up here.
All right. Whoa.
And then remember, point it that way you click it. Hello. All right, folks. Best speaker of the day, and I get to introduce him. This is Dr. Michael Kent. Dr. Kent and I go way back, but that's okay. We've been cleared by the parole agency, so it's all good. Dr. Kent is associated with Rich and Bone and Joint Clinic / UT Physicians. He's an orthopedic surgeon. He is a graduate of Texas Lutheran in Seguin, Texas. He was an All-American soccer. Well, he was academic All-American. He played soccer, but we want to say he was All-American. He is a hunter and fisher kind of guy. Anybody here hunt and fish? Anybody? Don't be shy. Hands? No? Oh, okay, thanks. Anyway. But he's been associated with the rodeo for a while. Good person. He's volunteered to talk to you about some injuries that we, both in the training room, the field house, the clinics, someone comes up to you and says, my father, my brother, my grandparents, my coach, somebody has injuries. So when we asked him to speak, this is kind of the seed we gave him and asked him if he would talk about some injuries in older athletes. So this is what he's going to talk about. So here we go, Dr. Michael Kent.
You're on. All right, good afternoon. Good God, volume works. I appreciate that, Mike. Mike and I met each other years and years ago when he was ending his athletic training career kind of formally at the Seven Lakes High School. I then went to work with HBU for a couple of years, and then now I work with Needville. Go Blue Jays. And so I am somewhat removed, however, from the sports world, and that a lot of my practice is centered around knee replacements. And so when Mike asked me to talk, I kind of thought, well, I'm not sure that I'm going to have all that glamorous a talk compared to what y'all hear all day. I know that you've heard about all the injuries that you treat on a daily basis, but this is somewhat applicable because I think that not only do people like Mike, as they get older, have problems with their knees, but also we have parents, and we have parents of the kids that we're seeing that have knee problems, and it's not uncommon. Y'all are very well aware that they might ask you a question or two. Certainly I've gotten questions from parents about their own knees or ankles or shoulders or whatever while on the sideline. That has nothing to do with playing sports, or at least at that point, obviously. And so I'm going to talk today about knee knee conditions, specifically knee arthritis, as it applies somewhat to what we're talking about with ACL injuries and meniscectomies and things like that. So I do realize, well, real quick, I guess I have to let y'all know nobody pays me because nobody really thinks my opinion is valuable enough to pay me for it. Therefore, I have nothing that would influence what I tell you today. So I realize you've probably seen this picture 4 million times, and this, of course, is very, very glamorous, and I think it's great. And you know, taking care of athletes that are at the peak of their sport is truly, truly an honorable thing to do, and it's really amazing to be able to take care of these people. I have treated NFL athletes or NFL players, however, mine look a little more like that. All right. And so the reason I make that point is that, yes, we look at a guy and like that and probably say, well, goodness, that's not exactly, again, as cool as that. But this person, that person needs love too. And so the good news is that as these athletes that y'all are treating are getting older, it used to be when I started into practice, 65 was really, really old. Well, now 65 is nothing. And so these patients are staying active for longer. And so that means that those injuries that they may have had when they were back in high school or back in college playing sports do certainly play somewhat into what they may be dealing with in their 60s and 70s. All right, so just to kind of put it in perspective, there's about 200,000 ACL injuries per year. Therefore, about 100,000 ACL reconstructions that happen per year. Every year, there's 50 million people diagnosed with arthritis, and there's about 600,000 total knee replacements performed every year. And so it's not to say what I'm doing or what I see a lot of is any more important than an ACL injury. It's merely to say, or just kind of put that in perspective as we think, there are those seasons where it seems like everybody tears their ACL. Well, there are those days, well, it feels like everybody has arthritis. Well, it's true, all right? So why does this matter to y'all, or should it matter to y'all? And the reality of it is treating young athletes, it probably shouldn't matter all that much. But part of the conversation that I have with patients, many times with patients that come in their 30s or 40s, they'll all talk about, gosh, I shouldn't have played high school football. I shouldn't have played high school volleyball. My knees are all shot because of that. The reality of it is that's not, in fact, true. A lot of this is genetically based. Many times when I'm talking to patients about arthritis, I compare the cartilage in the knees to tread on a tire. If you take really good care of your tires, they're going to last. But if it's a 50,000 mile tire, you're only going to get 50,000 miles out of it. The problem is we don't get to pick our tires. Okay, so we're born with the tires, and so you can thank your parents or they can thank their parents about whatever tire they were born with. If you don't take really good care of your tires, well, then that 50,000 mile tire, instead of getting 50,000 miles out of it, you might get 40,000 miles. Those things kind of sound like maybe being a little overweight. Injuries in high school and college and things like that, they do play into it. Something that's important to remember is that, yes, we go in and reconstruct the ACL, and I think that's very, very important. And obviously, there have been changes to ways ACLs are done now compared to the way they were done 20 and 30 years ago. In fact, there's changes now compared to the way they were done 5 and 10 years ago. So the goals with this whole deal with changing the way that ACLs are done is trying to make the knee work more normally. A point I have to make regularly to patients, though, is that normal knees don't get operated on. Okay, it doesn't mean that after an ACL reconstruction that patients can't return back. We know 87% of them go back to their pre-level function. Okay, so there's a very, very good track record as far as ACL reconstruction is concerned. That being said, that knee is still not normal because normal knees haven't had an ACL tear. Normal knees haven't required surgery to fix that. And so that does play somewhat into their future. And it's not going to say that, hey, because you've had an ACL reconstruction, you're for sure going to develop arthritis, but it is to say that certainly you have a slightly increased chance. Now, after we do the ACL reconstruction, there is a lower incidence of arthritis because the knee is working in a more normal way than it would be if there wasn't an ACL reconstruction. So again, I'm not trying to say that ACL reconstructions are futile. We shouldn't do them. I'm merely saying that we should do them. It is an improvement, and many patients go on and live a completely normal life. But once again, that's not a normal knee anymore. Obviously, meniscectomy, that's something that plays into this as well. It used to be, and many of the patients that I see, they come in with a telltale scar right over the medial part of their knee, and it's about 3 or 4 inches long. And basically what they were told when they were in college was, you know, meniscus ain't all that important. We're just going to take it out. All of it? Yeah, we're going to take all of it out. And so they used to do that. They used to cut the front part, the back part, and they just slipped that sucker out like a shrimp and put it on the back table, and they were done with it. And so we don't do that anymore, thankfully. In fact, you know, there's a lot of folks that when they're doing it, they've gotten more aggressive with repairing meniscus. And again, I'm sure there's been talks, or at least there will be talks about that sort of thing, because the success rate has gone up. So bottom line is that when a meniscectomy gets done, we want to do our best to take as little as we can, because guess what? The meniscus is important. Oh, excuse me. So just to kind of put this in perspective from a radiographic view, is that you can look at the knee on y'all's left and see that the joint spaces in between the femur and the tibia are very equal on the medial and lateral side. And so what will happen as we lose cartilage or lose tread, let me see if I can find the pointer, as we lose tread, we start to see this narrowing that happens over here, as well as the osteophyte or the bone spur that happens as a result of that. You can also see that in a weight-bearing view, the knee becomes a little more bow-legged. All right. And so when I'm at the movies with my wife and I'm walking behind an older couple and we're thinking, oh, they're so sweet, and I wonder how many years they've been married, or she's thinking that, I'm thinking, man, I could replace his knees. He's kind of walking like this, you know, and she hits me and I shut up. But bottom line is that yes, the most common deformity that will happen over time is called a varus deformity, and y'all are very, you know, familiar with that term, and it just means that they're becoming more bow-legged. So I say bow-legged in clinic because they understand it. But again, you'll start to see the narrowing of the joint space where that cartilage used to reside in bone spurs. Bone spurs, I could go in and remove every bone spur in the knee, and I'm not going to do them any good. The bone spur is a reaction. The bone is merely just saying, you know, I have pressure on me that I'm not supposed to have on me, and so the bone spur is a reaction. Removing it's not going to do them any good, like I said. All right, so osteoarthritis, that's a wear and tear arthritis. Many times when I say you have arthritis, a lot of times, or talk to a patient about having arthritis, especially if it's a female, she'll say, you're calling me old. I'm not calling you old. I'm just saying that your knee is worn out. Your knee is kind of old. You're just older. And so when I say that, there's a little bit of confusion, right? Because most of the time when we say arthritis, what I'm talking about is osteoarthritis, a wear and tear arthritis that happens over time. Again, the tread wearing off of the tire, the cartilage wearing away in the joint. Don't get that confused with rheumatoid arthritis or psoriatic arthritis. Those are far less common. Yes, they are big problems, and we see that occasionally, but not near as commonly as what we see when we're talking about osteoarthritis. How's that going to manifest? They're going to be a little stiff. They've been sitting for a while in a car. When they get up to walk, their first couple of steps really, really hurt, and then they get warmed up and they start moving around a little better. And so that's a pretty common thing that I hear. I hear about that I can't sleep at night because my knee is throbbing so bad. Why does it hurt when I'm not doing anything? Well, you're paying for the sins of the day. And it's not that you were doing anything wrong necessarily. It's just that all you have to think about at night is sleep and your knee pain. And so night pain is a very, very common manifestation of arthritis. Soreness, many times it's more of a achy sort of pain as opposed to a very sharp pain. They will complain many times of popping that can have a sharp pain associated with it, but many times it's going to be more of that achy kind of toothache, dull, always there sort of pain that they're feeling. Swelling, of course, is a function of this as well. Anytime we say the word itis, right? Inflammation, that deals with tendons, everything. We see that in all the various things, and of course the joint can swell as well. Most of the time, patients will say, you know, they come in to see me, I've been dealing with this for about 5 years, and it's just gotten worse over time. Every once in a while, we will see somebody, my mom being a perfect example, who just saw me 2 weeks ago. I wouldn't operate on her, but just to say that she came to see me a couple of weeks ago, and you know, up to 2 weeks ago, she was doing fine. So every once in a while, we see kind of an acute presentation of arthritis. And the way I tell patients about that is just to say, you've been walking on borrowed time. Your knee has been bad for some time, and fortunately, you've been kind of able to power through it. But the reality of it is that knee has been wearing for some time. It didn't just happen overnight. So those intermittent symptoms become more constant. I talked about difficulty sleeping, and then they'll also many times will come in and say, well, my leg's not straight anymore, you know, and every once in a while, about 8 to 10% of the time, they'll come in and they're more knock-kneed than what they can, or what they're supposed to be. Totally different animal, but the same process going on. Instead of the medial compartment wearing out, the lateral compartment is wearing out. Vast majority of the time, it's going to be the medial compartment that wears out first, and that's why they'll be bow-legged the vast majority of the time. So what are our treatment options? Obviously, non-steroidal anti-inflammatories, physical therapy, bracing, assistive devices, cane, walker, heel wedges, something, anything that we can do to offload that joint a little bit. Injections. Now, injections, that's something that y'all probably have either heard about, will hear more about as you listen through the course of the next couple of days. But, you know, there's a bunch of injections that are out there. Everybody's heard of the steroid or the cortisone injection, of course. Just for whatever it's worth, I'm not a huge fan of a steroid injection in y'all's age patient, okay? I'm not to say that people that are doing it, it's wrong, but I am just to say that truly it's something that all it's going to do is going to kind of calm down the inflammation. And by calming down the inflammation, that's great. But really, we'd kind of like to know, especially in a 17, 18, 20-year-old kid, what's causing it? Let's cure the problem. And so I'm not a huge fan of steroid injections. I'm 42. As I get older, of course, the age where I think it's acceptable gets older and older with me. And so I don't have any cutoff or anything like that. But I am a little hesitant. I've seen in fact, she was a basketball coach at Seven Lakes, or an assistant there at Seven Lakes. 32 years old, had one of the worst knees I've seen, and she had gone through, I think, played basketball at A&M, and she basically, her knee looked like complete and total garbage. She had had multiple surgeries, but probably more important on top of that, she had had multiple steroid injections, because the treatment was, hey, let's get you back on the court. Let's do everything we can. We'll give you a steroid injection, pat you on the rear, and say, have a good time. And so that can, over time, if administered inappropriately, it can have some deleterious effects on the joint. And so just keep that in mind. And again, I'm not saying change your referral patterns. If the physician that you talk to or refer to does steroid injections, I'm not bad-mouthing them. I'm just giving my opinion, which we've already determined really isn't worth much. All right. So viscosupplements, and so everybody's most likely heard about these. This is not PRP, this is not bone marrow aspirate, and we'll talk about those a little bit more. But viscosupplements, I always tell folks, it's kind of like an oil change in the knee. I go back to cars, right? The tread is worn out, but we talk about the oil change. Well, if your car has 50,000 miles on it, you take it in to get the oil changed, the parts still have 50,000 miles on them. The oil doesn't make the parts new again, okay? All it's doing is allowing those worn parts to function in a better environment. And so that's how I describe it to patients, just to let them know I'm trying to improve the environment in which your worn parts are working. But again, it's not going to regrow cartilage. You'll see all sorts of things on the internet. You'll see all sorts of things in the newspaper. You'll see all sorts of things on the news about regenerative medicine and all this stuff. And we'll get a little bit more into that. But unfortunately, that's not what's happening, okay? We're not regrowing cartilage. We are actually just lubricating the joint, hoping that it will work. The advantage to them is that 70% of patients get 70% pain relief for about 6 months. And so it's a longer period of time, whereas the steroid injections, I tell folks, about 2 months. Now, obviously, every rule is made to be broken, so that can be different from patient to patient, and I have that discussion with them as well. Typically, the viscosupplement injections, as well as the PRP and the BMA injections, those are reserved for my younger patients, and again, younger to y'all, not younger to y'all, younger to me. So anybody that's in their 40s and their 50s and even early 60s and really active with a mild to moderate degree of arthritis. If they have severe arthritis, viscosupplements probably aren't going to do them a whole lot of good, although if they say they want to try it because they've had an uncle that had it and it worked wonders, well, heck, we'll pop it in there. It's no problem at all. But just so y'all understand some of the science behind it. Again, it's not regrowing cartilage, not reversing that process of tread wear, because we can't rub anything on a tire and make the tread grow. We can't put special air in it. We can't put special gas in the vehicle. The bottom line, we can't drive backwards. None of that stuff. So we'll talk a little bit more about, and something that I think is important, a process that y'all start with most of your patients and most of your athletes. The two things that are important as far as what can patients do to prevent the progression of arthritis: stay active, maintain a healthy weight. It's very simple, right? Stay active, maintain a healthy weight. Activities that I typically recommend: swimming, biking, elliptical trainer, and walking. I left running off of that. That does not mean that I think running causes arthritis. If you have genetics that say you're going to get arthritis, yeah, it may accelerate things a little bit, but it's not to say running's bad. I run. I don't want a knee replacement if I don't have to. So bottom line is it's a good exercise. The second part of that, of course, is maintaining a healthy weight. Y'all know more and more as you look at your students that many of the folks that you're treating are becoming larger and larger. And in some cases, that's a really, really good thing, right? You know, I mean, we want them to be able to push the opposite team out of the way or whatever sport they're playing. It's not always a bad thing, but it is something when y'all are counseling patients about weight and things like that, it is an important thing to kind of keep in mind as far as their future is concerned. So I'll get back and talk about, we'll talk about PRP and BMA in just a second. So we have offloading braces. Essentially what that does is they say, okay, your knee's headed this way. We're going to try to push you this way. Looks kind of like an ACL brace, you know? So what we're trying to do is, again, offload that area by pushing their knee in a more normal alignment. I haven't found them to be really, really effective because everybody's body is not made the same way. Therefore, the braces don't always fit. And y'all have all had students that y'all have put in ACL braces following an ACL reconstruction. They say it slides down, it won't stay where it's supposed to, all that sort of stuff. And I agree, because everybody's leg is a little different, and so there's been some changes made to that. But most folks, as they get in their 50s and 60s, they're not really all that excited about putting a brace on every day over their pants and walking around in that. Again, it's not to say it's a bad idea. It's just something that in application, I haven't seen that patients have been extremely over-impressed with that. All right, so platelet-rich plasma injections. Y'all are all, I'm sure, very familiar with this. I think this is a good thing that's out there. It's been shown to be equivalent to the visco supplements or equivalent to the oil change, all right? And so it's something that we use in our clinic fairly regularly. Once again, it's usually patients that are in their 40s, 50s, maybe early 60s. And again, I don't treat birth certificates. I treat how they act, what their x-rays look like. And so I don't, again, put people in categories based on, hey, you're 65 years old, therefore you are not a candidate for, because again, that's different from patient to patient. Essentially what's done, you draw some of their blood, you spin it down in a centrifuge, you grab the platelets off of it, you mix it with some magic crap, and you inject it back in their knee. All right. So, I mean, once again, it's not something that's going to regrow cartilage. There are a lot of people out there that are charging $1,200 for each injection. The FDA hasn't approved its use, and so they do have to pay out of pocket. There's a lot of people that are getting very wealthy off of these injections, telling patients that you're going to avoid a knee replacement if you have this injection. It might help, but they still might need a knee replacement. Okay. And so again, I'm not saying it's a bad thing to do. I'm merely saying it shouldn't be sold as something, you know, that's going to reverse the arthritic change in their knee. The platelet-rich plasma or the BMA. So bone marrow aspirate, this is the needle we use. And believe it or not, even though it's blown up on the screen, it's not a lot smaller than that. It's pretty large. And so what we're doing essentially is we're taking this big old hollow core needle and we're shoving it into their pelvis, or we're shoving it into their proximal tibia or their proximal humerus, just depends on what we're doing. And we're taking some of the bone marrow off of it and again, preparing it and then injecting it back in to the knee, let's say in this case. You'll hear about a lot of this getting done in ACL reconstructions and rotator cuff repairs and labral repairs and stuff like that. Again, trying to enhance the healing power that's in that joint. And so again, a very, very good thing to do there. What I don't want that to translate into, again, is that we can take some of your stuff out of you, inject it into your knee, and all of a sudden your knee will be new again. That's not going to happen. The process of arthritis is a very diffuse change, right? Instead of having one specific focal chondral defect, we have a lot of cartilage that's missing. And instead of that being a well-contained pothole, if you will, just the whole road sucks. And so because of that, we don't really have a way to deliver it into the knee that it's just going to stick to the bad areas. There are ways if it's an isolated defect. And I think, again, in the sports world, that's a very, very important thing. And especially if we've got somebody that's in their, you know, teens or early 20s, we don't want to just be okay with the fact that they have a big defect in their cartilage. If it's a well-contained defect, using BMA in conjunction with some of the scaffolds that are out there can be extremely effective. And so, again, this does not, I don't want this to translate into what you hear or think or tell your athletes. All right. So usually after we stick this needle in them, they kind of look like that. Most of the time, if I'm going to do it, I'm going to do it asleep just because I don't like that face in my clinic if I don't have to see it. But I thought it was kind of funny. All right, so what's the total knee replacement? It's actually a knee resurfacing. Everybody thinks that what happens, many patients anyway, y'all probably don't, but many patients feel like what I go in and do is I cut the leg off here, I cut the leg off here, I chunk all that on the back table, and then I put this extremely large mechanical contraption in their knee in order to give them an entirely new knee. Well, the ACL and PCL are sacrificed. Both the medial and lateral meniscus are sacrificed. but most of everything else stays intact. So patellar and quadriceps tendons, all the tendons in the back, that medial collateral ligament, lateral collateral ligament, all stay the same. A knee replacement has always been this way, but it's called a knee replacement. And so patients understandably think it's the big thing that I'm talking about. And the reality of it is it's a knee resurfacing. So again, back to cars, it's kind of like retreading a tire. A lot of the tire stays theirs, all right? So we're removing the worn bone and cartilage from the end of the femur, the top of the tibia, and the back of the patella. That's replaced with metal and plastic, and it's held in place with cement. We don't use screws anymore if we can avoid it. That creates some issues that really y'all probably don't care about. But ultimately, I always tell my patients, it's really fancy metal, it's really fancy plastic, and it's really fancy cement, but it's still metal, plastic, and cement. That leads kind of into our therapy discussion afterwards. But bottom line is it's all hard objects that they can walk on, put weight on immediately, and I'll talk a little bit more about that in a little bit. Obviously, part of the job is not just to give them new surfaces, but take their bow-legged knee and make it a little knock-kneed like it's supposed to be. We're supposed to be 3 to 5 degrees knock-kneed, and so that's part of the correction that happens. Can help the hip, can help the ankle. I don't sell it as that, nor am I trying to sell anything, I guess, but ultimately I tell them, if you have a hip problem, you're still going to have a hip problem. If you have an ankle problem, you're still going to have a hip problem. However, if the knee is appropriately aligned, that can be a good thing in the future. And so again, that's why we continue to try to help not only with the surfaces themselves, but also the deformity. So this is again what I was talking about. I'm not going in and removing the bone here and here. I'm essentially just taking the surfaces off, and we do make it shaped basically like that. Part of the reason I went into orthopedics is because drills and saws and hammers are kind of cool, and I get to use them in people. They're just really, really clean, and so I really, really enjoy that, of course. And then we put something that resembles this there, and there will be cement that's basically at that interface, cement at this interface. This is all modular, meaning that we have choices as to the sizes and things that we can use so that it fits the patient. We're not just kind of one size fits all kind of doing this. This is what it looks like post-operatively. And of course, in the x-rays, they can't see the plastic. That always confuses them. Did you forget to put something in? No, I don't think I did. Anyway, and so so this is again kind of comparing what does it look like before, what does it look like after, and you can see the drastic change in the deformity itself, and then also in the space between the two. Once again, not being able to see that plastic. So when we talk about knee replacements, the advances, a lot of times folks think it's because the incision is smaller and the therapy, you know, all this sort of stuff. And the reality of it is that the implants themselves are fairly similar to what they've been for a long, long time. So there's not big changes that are made in the implants other than the plastic. The way the plastic is sterilized, the way the plastic is stored, the way the plastic is cross-linked, the way, I mean, all of those things, that's been the biggest change, because that bearing surface is what would degrade. When those particles would degrade, it would help to loosen the metal. And so the longevity of these implants has gone up, mainly because of changes in the bearing surface itself. 20-year survivorship, 80%. And so patients always ask me, well, how long is this thing going to last? Well, I see thousands of patients every year with knee arthritis, and the vast majority of them are not coming in saying, my knees wore out. Okay, and they may be 20 years out, and they'll come and they might have some pain, but the reality of it is it's not because the knee is worn out for most of the modern era implants that are put in. It's a little different world, because you think an ACL reconstruction, you know, recovery is a long time. We'll go ahead and put a knee in somebody and see them 20 years later. You know, it's a little different in that respect. So we don't have data or we do have data, but short-term data and knee replacements really doesn't mean a whole lot to us. We expect them to be doing well at a year and 5 years and 10 years and 15 years. And so changes that are made do take a while to kind of cycle through, so we can completely and totally understand if we actually made a difference with some of the changes that we made. The other thing that we're doing, and probably the biggest change, is multimodal pain protocol. And so what does that mean? We used to just give morphine. We used to give codeine derivatives orally, and they would get constipated, they would get nauseated, they would vomit, they would hate us. I'd walk in the next morning after surgery, they'd want to hit me with a baseball bat, and I can't blame them really, because they not only were they constipated and throwing up, but they also weren't feeling all that great. It was hurting like crap. And so what we've gone in and done is really rethought the way that pain is treated. And pain is treated with oral medicines prior to, not narcotics. Pain is treated with injections that we give during the surgery in the posterior capsule, the periosteum, the subcutaneous tissues. It's also treated with a different type of regional anesthetic that doesn't shut down their quads so they can get up and start moving right away. And then, and so we don't even use morphine anymore as a pain control agent because we don't need it anymore. Patients the next morning, you'd be surprised at how many patients, after I've done what I've done to them, I walk in the next morning after surgery and literally they're complaining of a pain level of 0. I never would have believed that 10 years ago. I mean, it just doesn't seem like that's possible. But bottom line is that if you've had family members that are considering this, the old way of managing pain is very, very different now. And so we are getting patients less pain quicker, which leads to a lot of other things in that we're mobilizing them early and getting them into outpatient therapy. A lot of times they'd stay in the hospital 3 or 4 days and then have to go to a skilled nursing facility or a rehab facility. A skilled nursing facility is what gets approved by insurance. That's like a glorified nursing home. I'm not doing this surgery on people who belong in nursing homes. I'm doing this on patients who don't want to be in a nursing home. They're walking like they belong in a nursing home. But after surgery, we don't want them feeling that way or looking that way. So I don't want them treated there. So what are some of the changes? Again, it used to be a 3 or 4 day stay in the hospital. Folks were on the CPM, the machine that moved them real slowly, for about 6 hours a day. We've stopped using that because we've decided that 6 hours could be used in a much more productive way. SNF or rehab or skilled nursing facility versus rehab. Now they go home, and then we used to use staples. Now we use absorbable sutures. We use the Dermabond glue, and we use an occlusive dressing. And again, a lot of that probably y'all don't care too much about, but it's all to help fight infection. It's all to get them mobilized quicker. And strangely, you know, I think right now my length of stay in the hospital after total knee is 1.1 days. And so that's average all comers. And that's not just my 62-year-olds that get a knee replacement. That's all the way up to my oldest is actually 89. Don't think less of me because I said I did it. But bottom line is that 89-year-old is whipping most of my 59-year-old's butt. And so I threatened to bring him in regularly and say, hey, look, this guy's like 30 years older than you. You kind of suck. You should work harder, you know? So, you know, he'll tell you. Anyway, so again, I do realize that this isn't a horribly glamorous sports talk. It doesn't deal a whole lot. I wasn't lying. I do have NFL former NFL players that come and see me, and I do their knee replacements. Very rewarding because they still have that mentality about therapy and things like that. So it makes a huge, huge difference as far as recovery is concerned. And I just figured I'd put a couple things up that were kind of funny about old people. So there's that. No offense, Mike. And and this is just funny. And so anyway, if you have any questions, I'm here for you know, however long you want me to be or until they kick me off the stage. But I'm happy to answer anything that I can answer.
Don't be shy. We're not going to charge.
Yes, ma'am. Yes, I have heard of prolotherapy, and the jury is still out. It's a good thing, and I'm all for that. I always tell folks, hey, if you wrap a chicken liver around your neck and it makes your knee feel better, wrap it up. You know, I mean, I'm totally fine with that. I mean, just because I don't completely and totally understand it, I don't have any problem with it. What I don't like is when people are selling things for unproven reasons for a lot of money. It just doesn't, that doesn't sit well with me. But do I think it's a wonderful adjunct in a way that can help them get better? Yes, ma'am. Anybody else? Yes, ma'am. So typically, no. Yes, you can have hip arthritis and knee arthritis, but having knee arthritis doesn't necessarily increase significantly your risk of having hip arthritis. It's amazing how much more common knee arthritis is than hip arthritis. Knee arthritis, we see, you know, you'll see 50 or 60 of them, and then you'll see 1 or 2 hips. And so it's just grossly weighted in the knee world. And if knee arthritis was causing hip arthritis, that ratio would be a lot closer to 1 to 1. Yes, ma'am.
Your elderly athlete.
Yes, ma'am.
That's still your ex-football player that's still playing pickleball or whatever.
Yeah.
Do you ever salvage the ACL, MCL, or ACL? can do a unilateral replacement on each side?
Yes, and that's a great question. And so partial knee replacements are something that's out there, and it's a great operation. I love partial knee replacements. The problem is that partial knee replacements, if I have 100 patients that come into me for a knee replacement, okay, that they're candidates, they've tried all the non-operative stuff, 100 patients come in me for a knee replacement, only about 10 of them, maybe 15 of them are actually going to be candidates for a partial knee replacement. We have to know for a partial knee replacement on the medial compartment that they have an intact ACL. We need to know that those other ligaments are intact as well. We need to know it's a correctable deformity. And so there's a lot of criteria, and I'm a real stickler for criteria. And so when it comes to that, I don't push the indications at all. It is a wonderful operation. There actually is a knee replacement out there now that that preserves the ACL, the PCL, the MCL, and the LCL. Technically, it's a little more difficult, but difficult shouldn't stop us from doing anything. But the jury is definitely still out as if it makes any difference, because I've got patients that I'd be willing to put up against those, and I've done those types of ACL or ligament preserving knee replacements. And again, I think there's some value in exploring it. Once again, they came out, within the last 5 years, and so we're waiting on 20 and 30-year data. And so unfortunately, I guess I have to keep practicing to find out if it actually worked. Anything else? Yes, sir.
How many oil changes?
I'm sorry?
How many oil changes? How many times can you do it?
Yeah, so there's really no limit to the number of oil changes that you can have. However, every time you do it, you have a higher incidence of an aseptic reaction to that, meaning it's almost kind of like an allergic reaction. It seems kind of like an infection. I've only seen it about 3 times in my practice after just thousands and thousands of these injections, but it's always been in their 2nd or 3rd course. Vast majority of the time, if people have had 2 and 3 courses, it just doesn't seem to be as effective anymore. I always tell folks it's kind of like you're peeing on a forest fire at this point, or you brought a knife to a gunfight. Is that the monster that you're trying to kill is just bigger than what you're able to kill with that injection. So again, you can have it as many times as you want, and I don't mind doing that. As long as they're getting good relief and they're not having a reaction to it, I don't stop them from doing it. Most of them stop themselves. They'll tell me, the last one wasn't all that effective, and so I don't know that doing that again is going to be effective at all. Anybody else? Yes. PRP with that injection? No. And it's just because both of them are equally as effective. They have not been found at this time to be additive, if you will. And so, do I mind doing it? Heck no, I don't mind doing it at all. We don't charge $1,200 for those, by the way, just for the record. We charge a little over what the kit costs us, so because patients need it, we're not trying to rape them. Yes. Say that one more time. You said infection and joint replacement. Yes. So better, and in fact, that's one of the big things that we've been working on out in our area, and actually system-wide through Memorial Hermann. It's a big deal, obviously, because a lot of folks think that if I get an infection on a cut in my skin, I can just wash it with soap and water, I take some antibiotics, and it's going to go away, right? Well, an infection after a joint replacement, I have to tell patients this, because now we're getting really dialed in on, is their BMI over 40? So are you classified as morbidly obese? Why do we care? Well, it makes the surgery a little harder, but once again, I don't shy away from hard. I'm shying away from infections, and so your infection rate is higher. Hemoglobin A1C, how's your diabetes controlled? If your diabetes isn't controlled effectively, well, then you're obviously at risk, higher risk for infection. So we're really, all of a sudden, the bone and joint guy, the stupid guy, has to start paying attention to labs and weight and all that other stuff. And so, yes, it's very important. The incidence is about 1%. We shoot for 0%, right? Is 0% reasonable? Probably not, but we're going to get there, okay? Or we're going to get as close as we can. We're making sure that people have stopped smoking. We're looking at their albumin and pre-albumin levels, all these things that before, again, we just never even thought that were all that important or that were big factors. And so because infection is now publicly reported, and it is such a devastating complication, real quickly, when they get a joint infection or a total joint infection, it's not unusual that you open the knee up, you take all those implants out, you leave them out for 3 to 6 months, they get 3 months or so of IV antibiotics, they walk around essentially without a knee for that entire period of time, and then they get to go through it again, and the risk of infection is still higher. So I have to tell patients that when I'm telling them, hey, you know what, your BMI is at 42. I really need you to lose weight. Well, I can't lose the weight. Well, I probably can't do your surgery. And why? Because I don't want you to get infected. So the rate is about 1%. We're shooting for 0, and we made big changes, or we're continuing to make changes literally every month to try and help fight that. Great question. Anything else? Well, thank y'all. I do appreciate it.
Right. Well, thank you. You should probably wait till the end to see if you want to clap or not. But I thought Dr. Kent's talk actually was my introduction because I was a young athlete that became an old pseudo-athlete and wound up getting a knee replacement a couple of years ago after putting it off for a long time. And I can tell you, I wish I would have done it years earlier. Just that, as you said, it's a lot easier than it was years ago. I was out of the hospital in less than 2 days and back operating in 7 days and played golf in 16 days, and I'm hitting the ball longer again. So I recommend it. In fact, a bunch of my friends decided if I was going to hit the ball longer, they were going to get a knee replacement too, even if they didn't need it. Just like some of my friends, I did a regular hernia on a guy who was an attorney here in town, and 6 days post-op, he shot his age, which was 72 at the time. And so then I had this big influx of people from the country club wanting hernia repairs because they thought they'd play better. But so we're going to talk about something called sports hernias, which is a bad name. And as you'll see, it's misunderstood. And I got into it after a long time. I've been doing hernias for 45 years. And then about 14 or 15 years ago, I decided after I left MD Anderson to really concentrate. I was doing hernias and stuff on the side and helping them out over there, to concentrate my practice really on hernias first. And that led to me for really a better understanding of the anatomy of the area. And so then it led me to being involved with sports hernias, which no one really wants to do. So I'll be happy to go through this a little bit. And then I have no disclosures. My wife's a plastic surgeon. She has all the money. So I just kind of, and the rest of it goes to my grandkids. So, you know, like that. So sports hernias are really misunderstood, and physical therapists, trainers, and a few orthopedic surgeons understand this entity. Most surgeons, even, let alone most doctors, don't even believe it exists. I'll give you an example just today. At 11 o'clock today, before I came over here in my office over in Bel Air, I was seeing a patient. Now, and athletes are all ages. This guy happens to be 71 years old. He's from Galveston. He ran the Boston Marathon. He was getting ready for the New York Marathon. Since February, he's had chronic groin pain. And he's gone to, on his own, he went to 3 or 4 different doctors and surgeons, and they all checked him and said, you don't have a hernia, you're just going to have to get over it. Well, the guy is excellent shape, and he runs all the time. So even though he's 71, some of the attitude of some of the doctors out there will say, well, just quit doing it. And I do that once in a while. I mean, I did have a 43-year-old attorney that came in and said when he got in some crazy position like this, he had pain right there. And I said, don't do it. And but this guy's serious, okay? Finally, he went to a physical therapist who said, you know what, you're having this chronic pain. Why don't you go see him? And I just saw him. And actually, he wants to get back in shape so fast. I'm going to operate on him tomorrow morning. But I'll tell you, it's very misunderstood. Now, I want you, I don't know about you, but if some of you want to tell this guy that he doesn't have pain and that this doesn't hurt and that the entity doesn't exist, you can do it. But I'm not going to go tell him that he's faking this, okay? Because he's a pretty big guy. There's all kinds of names for this, okay? And anytime you see something that has multiple names or multiple different thoughts about it, you know that people don't understand it well. And you probably all heard this, everything from Gilmore's hernia, groin disruption, soccer groin. Really what it is, it's pain in the groin, and this area is very sensitive, and there's a lot of radiation from the back, from the hip, and other areas. So you really have to understand the anatomy, which is very confusing. And I will guarantee you, after teaching residents and faculty and people for 45 years, most surgeons that are even doing hernias don't understand the anatomy. They just fix the hernia without understanding all the details. So probably athletic pubalgia or groin pain is probably the simplest thing. And the problem is that these people most of the time don't have hernias. What is a hernia? Well, a hernia is really a weakness or a hole in the floor with intestines or fat or something coming through it. Most of the people that I do hernias on don't really have pain unless it's pushing on a nerve or something. But patients with sports hernias come in crying of pain of various levels, okay? Let's see if we can get... Now, the reason it becomes problematic is that there's all these different places you can have hernias. You can have them from previous incisions. You can have epigastric. You can have umbilical. Then in the inguinal area, where there's so many nerves and it's so sensitive, you can have a regular hernia that can be fixed, or you can have this chronic groin pain that needs a different approach. And it's pretty simple. I had several guys in the office this morning that came in with a bulge. Pretty simple. That's probably a direct inguinal hernia. We can go in, make a little incision over, push it back in, and I'll show you how we fix it. And then you can have a direct hernia, as you see here. See if this shows up here or not. And an indirect hernia, like you have in children, but sometimes they don't open up until they're adults. And there's a little sac that comes down from where the testicle comes down, because embryologically that testicle starts by the kidney and then has to move down. And if that sac reopens, then you can have intestine, and you can have all kinds of things in there. And so you can fix those pretty simply. And then you can have inguinal hernia, you can see down below. The femoral hernia above, most commonly seen in women that have had children. That area gets a little lax beneath the inguinal ligament, and it comes down along that nerve, artery, vein, and lymphatics there. And so occasionally you'll see that in a man, but it's more common in a female. And this anatomy has been talked about for years of being very misunderstood. And I have to admit that even though I've done hernias for 45 years, it's probably only since about 2001 that I really understood what I was doing. And so you'd have to understand there's these triangles. I'm not going to teach you all the anatomy of this area, but there's a medial triangle, a lateral triangle, and a femoral triangle, and you can get hernias through those. And how do you fix those? It's real simple now. Starting in about 2002, I started using this little Prolene hernia system, a little mesh that I put in there. And I've done about 8,000 of those now since 2002, which makes the pain much less. Outpatient, go home within an hour. They can shower, eat, walk that day. And I have people going back to playing sports, and depending on age, everything you heard about, weight, health, maybe a week to 4 weeks, depending on how big they are. Now, and this just shows you the mesh in place. It's really simple. So that's a hernia. And you got to remember, some guys really like their hernias. And these guys think that this really dresses up a man. Most places in the world don't like this. The nice thing about this technique, I can do it in the operating room. I can do it in a third world country. I can do it under local, all kinds of stuff. Now, in the past, it was really bad because, as you can see, these guys in the past, in order to fix hernias, they would just chop off the testicles and the scrotum. And obviously, this guy here in the middle doesn't look too happy with this. So this is why there's confusion, because people say, well, you've got a hernia. You go into a doctor and he says, you don't have a hernia. You're just going to have to get over it. Well, a sports hernia is a strain or a tear, injury to the groin or the lower abdomen. And there's multiple things that go into this. So if you go in with one idea, you're going to miss most of the patients. And because this is so different for most people, they don't understand it. And to be honest with you, the only reason the quote incidence of this is going up is because trainers and physical therapists and a few orthopedic surgeons understand and realize this is a real entity. If you talk to a lot of my surgeon friends here in town, they're going to tell you this doesn't exist. You're crazy. They just got a little pain. Wait, give them some some anti-inflammatories and wait till it goes away. Well, there's several different things that can happen here. You can have a posterior wall injury. You know, the intensity and the training that goes in today are amazing to me. I played college baseball, football, and a scholarship for baseball. Nothing like it is today. I have two grandsons in high school. He mentioned Seven Lakes, one playing sports there and the other at Westbury Christian. These kids, when they're 15, 14 and all, they already have trainers and strength coaches and all kinds of stuff. We didn't have any of that when I was going to high school and college and all that. And so they're in such good shape, and the intensity is so hard that we're seeing more of this as well. So it's recognition and the fact that the athletes are in better shape and more expected of them, and it's a higher intensity injuries. So it's been suggested that, like I said, that this may be increasing in incidence, but I think more or less it's recognition and what's going on. There may be a bit increase in the severity of the injuries because of the endurance and the training and the intensity. And most doctors won't recognize this at all. So I think all of you know this. I mean, everybody in this room probably is familiar with the entity of groin pain, either the things that happen with soccer and with hockey, with sprinting, with all kinds of different issues, like the guy today, 71-year-old, that's a marathon runner. And what happens a lot of times with these athletes, why does somebody in good shape like JJ get injured? Well, they loosen up, they warm up, and then they go out, play a little bit, and then they come back and sit and rest for a few minutes. Things tighten up. Then they don't loosen up again, and they go right back out and try the same intensity, and the things get ripped. And so we're going to look at some of the now. I'm not going to try to totally make you understand all of this because it is a complicated area. But you can imagine here, you've got all this external and internal oblique. You've got the rectus fascia coming down. You got the adductors coming up in here, and then you're putting a lot of pressure on these areas. And all these muscles in here, let me just see, there's the pointer is right here. Let's see if we can see which one this is here. Well, that's okay. Here we go, I think. Well, if you look at the adductor longus right there, that's one of the ones in this area that gets damaged most frequently. Right at the attachment there, adductor longus, you see the little white attachment to the bone right there. And I think I got a couple better pictures that I can show you here. So what you see here is you've got the muscles that are all very well developed, and they're pulling in different directions. So you've got the external and internal obliques here, the rectus here, and the adductor here. These are going to contract and pull this way against the bone. These are going to contract and pull up way against the bone. So one of the first things that can go is the external oblique can rip, and the transversalis are very thin. So on the layers over here, you have the external oblique, the internal oblique, and the transversalis. Down here in the groin, you have the external oblique, and then there's an opening for the external ring. You have the internal oblique, which is lateral and medial. It doesn't come all the way down. And then you have the transversalis, which is very thin. Both of those can get ripped very easily. And if not there, then the adductor can go as well, depending on where the main strain is. So since they attach both of this, and I put some of this in, I won't spend much time on it, but since all these muscles attach to the same area, the bone, the pubic ramus, pubic tubercle, you can imagine if one is contracting this way and one is contracting this way, something has to give, okay? So if you look here, this just shows you again what goes on here, the contractions in the different areas. And so the weakest area, and depending on how they're pulling, is going to pull. So most commonly, you'll see external oblique injured first, then transversalis, then rectus, and then adductor. And you've got to be sure you know which ones the patient has. And sometimes you don't know till you get in there. And you can tell this a little bit, like the guy today, his major problem was when I touched the attachment of the adductor to the pubic tubercle, he had severe localized pain. So you can inject it, you can get minor relief for a period of time. Most of these patients, unless they want to quit working out and exercising, it's going to come back. Occasionally, you'll have a bleed or a tear in the muscle itself. Most commonly, it's right where the adductor attaches to the pubic tubercle. And so it's easier to take care of even than when it bleeds into the muscle. Now, what do? Well, this is what you're all very familiar with. You know, you heat it. If you look at athletes, when I get athletes, they're in the middle of a season or so, or what I'll do is we'll warm them before they go out. We give them anti-inflammatories before they work out. There's a tendency for many people just to take Advil, Aleve, all those things after they already have the pain. You want to give it to them before they do the workout because it decreases the inflammation. And then afterwards, you ice it. So it's warm and then ice, okay, afterwards. And if all of this doesn't work, then usually they start to get a workup. And I get some patients in that have had multiple MRIs, CAT scans, ultrasounds, all kinds of stuff to rule it out. And the reason for this, a lot of times they'll come in to the orthopedic surgeon or some other doc with what they think is hip pain, or they'll have groin pain that's radiating. So you really don't know what the problem is. Is it coming from their back? Is it coming from their hip? And these guys are in really a lot of pain, most of them. As you can see here, he's definitely not happy. And we call it the like stuff, but you know, I see it in so many different sports, not just, it's real common, obviously, in soccer or hockey, but I see rugby players, I see sprinters, I see football players, all these people that are really in good shape and then have a sudden intense release of muscle mass. One of the things, the MRIs and all this kind of stuff, ultrasound, are more of a help to rule out other problems. And so if you don't really know what's going on, a lot of the golfers that I take care of over the years would have labral tears that would radiate into the groin. They didn't really have a true hernia, and they didn't have a true sports hernia. They had a labral injury. So you want to be sure that it's not coming from the hip. But in general, all these studies don't really help you very much to find out what's going on with the sports hernia. So I'll give you another example. This is a 28-year-old guy from here in town that does powerlifting. And he would warm up, do the big powerlifting, and he'd powerlift like this, if you know, and he ripped the attachment of the adductor longus away from the pubic tubercle partially. So then he waited a while, got some injections, kept going back after it again. And what had happened there is not only did he have a chronic pain and tear, but the pubic tubercle and the bony attachment became hypertrophied. And so I've seen a number of patients now that have had chronic problems with the attachment of the adductor where they get hypertrophy of the bone. And in addition to releasing the adductor, I actually have to go in there with a chisel and I feel like a real orthopedic surgeon then, you know, get all these toys that they play out, the chisels and hammers and the rongeurs and all that. And so I get to play a little bit like that. And you take off that bone as well. And so what he had mainly, his pain mainly came from the adductor, although you've got to look at other things in the groin while you're there. So what do you find when you go in? And like I mentioned, sometimes you don't know exactly what you're going to find. First of all, you go in, sometimes you'll see edema of the tissue. Just like when you sprain an ankle, you're going to get swelling. If you have injury to the groin, as you go through the tissues, it doesn't look right. These are young people. They shouldn't have that edema in there. Then you get down to the external oblique, and you can see that it's attenuated and spread out or ripped, sometimes ripped like they're an 80-year-old guy. Then you open that up. A lot of times you'll find problems with the nerves, okay, the ilioinguinal and the iliohypogastric nerves. Sometimes It's bled into the area. You have scarring. I've seen where they've had neuromas. The ilioinguinal and the iliohypogastric nerve can swell. You can have chronic pain. We also see this with regular hernias, sometimes with recurrent hernias, where people have gone in, put stitches through the nerve and didn't see it because they don't look for the nerves. So they can also have associated problems like a varicocele or hydrocele, partial disruption of the adductor, tear of the external internal. All those things can happen. So when you go in, you have to be prepared to take care of all of this depending on what you find. And at this point, there are no good studies that can tell you exactly what you're going to find when you get in there. So the first thing I do when I get in is I look at the external oblique. Is it ripped? We're going to open it anyway, so we're going to repair it. And then you go in and you look at the nerves. And these are misunderstood nerves. There's actually another nerve, the genitofemoral, that comes out with this, but most commonly through the open approach, you're going to damage if you're going to have a problem with the ilioinguinal or the iliohypogastric nerves. And you can see a lot of times these patients have had multiple injections. They've had bleeding into the area. They've had tear of the muscle, all of which leads to scarring and then chronic pain. So you got to get rid of those nerves. And I'll tell you about that in a second. Okay, and then you take the cord structures and you pull them over, make sure they don't have a hernia. Less than 5% of the patients with sports hernias have a real hernia. They may have a weakness of their posterior floor. If they do, you can either repair it if they're young, or if it looks like it's starting to bulge, I can put a real lightweight mesh in there. I have these Ultra Pro and things that I use on thin athletes and stuff to protect the floor. Okay? And then this just shows you sometimes all you have to do is repair the floor before you repair the external oblique. You remove the two nerves. And the nerves give you transient numbness beneath the wound and into the thigh. That goes away in a couple of weeks. The other nerves take over. So these are sensory nerves. Most of the people are so happy to have pain relief that they don't care that it's a little numb for a couple of weeks. And then afterwards, the sensation comes back from the other nerves. Now, there's a big controversy with some surgeons saying, couldn't you do this laparoscopic? I do a lot of laparoscopic gallbladders, appies, other things like that. But if you think you can do this all laparoscopically, then you don't understand the anatomy, because you can't get to the adductor, you can't get to the ilioinguinal nerve, you can't get to the transversalis or any of those. You can repair the posterior wall if you have a hernia, but you can't do all the other things that cause pain in these patients. So I do not like the laparoscopic approach. Generally, if they do a laparoscopic approach, they have to go in anterior as well to fix it, okay? Now, what do I let them do? Well, they go home the first day because we have super glue on them. They can shower, they can eat, they can walk, they can do whatever they want. First couple of weeks, they can go to the park and walk as much as they want, or stationary bicycle or so, but I don't want them to do heavy lifting, straining. Then they get 2 to 4 weeks, depending on how severe they are, of physical therapy, training, get back in shape. And then we start up on a program to increase their activity again. So if it's done properly, most of these people are back playing sports in 4 to 6 to 8 weeks. They can do regular things like get around, go to work and all that in a day or two. Now, I'm going to summarize by saying this is, again, really a misunderstood thing. And it's become almost the people think it's really crazy. Some docs here think that this doesn't exist. Why are you doing it? Other doctors, there's a doctor in Philadelphia, for example, who I've known for years. He was a transplant surgeon. Then he went to Massachusetts. Then he opened up this clinic in Philadelphia. I've known for like 35 years. And people go from all over the country, all over the world to him. He charges cash only, about $50,000 to do this. And he owns the clinic and all that. And why? Well, because there's very few people in the country that are willing to do this for insurance. And there's probably, I don't even know of many people in this area of the country that are willing to do this, because it takes the time to understand this anatomy and know what it is to get them to do it right. So I think there is increased recognition now by you all, not by most general surgeons yet. And I think the things I mentioned, that if they don't respond to conservative therapy, and believe me, I try to talk people out of it. I spend more time trying to talk people out of things. I get these 12 and 13-year-old junior high school athletes in there, and I try to talk their parents out of it. And I want to see how serious this is, because sometimes you're treating the parents and not the kid. And sometimes I got to find out if they really, really are having this chronic pain, or what have they really done, or do they want immediate access? And I tell you, one of the other things you have to be careful. I've been doing this for a long time now. The worst possible patient you can have in terms of postoperative pain is a 22 or 25-year-old male, okay? They are the biggest babies you will ever see in your life. Females seem to do well with pain. Older men are happy to be alive after the operation. Older women have had children and all this stuff. You give me a 22 or 25-year-old perfectly healthy male, and I can promise you he's going to think he's dying after the surgery, okay? So that's another reason why people don't want to mess with this. But it's a real entity, and we have to be sure we screen out the ones that don't need surgery first. And so I don't really operate on everybody I'm sent, but most of the time other people have seen them and worked with them for months or years before I see them. So I'll just say, I think that that you're going to see, if you just talk to a lot of different docs on the outside, they're going to tell you that this is just kind of make-believe. I think that in your own practices and all, you're going to see that this actually exists, and try to, see if you can treat them conservatively first. But if they don't, then have somebody see them that's taking care of this. Questions? Rebuttals? Okay. Excuse me? I'm sorry, I couldn't hear you. I was asking about bedside sonograms, and so yeah, I think there's a couple things you can do there. Sometimes you can see if there's a real hernia, okay? Sometimes you can see if there's scarring or other things, or some people say, I can't do it myself. They can tell whether or not there's a labral tear or so like that. I'm not good enough with the ultrasound to do that. So if I think there's something else going on, I'll get a formal ultrasound or MRI. And if you're going to order any of these tests, make sure that the people doing it understand that you're ordering it for a sports hernia or an injury. Otherwise, they'll just do a routine MRI or ultrasound, and they won't look at what you're interested in. So you got to be sure that you find a imaging center that does it properly. Not everyone will do it. Other questions? Yes, ma'am.
I had an athlete that had a pretty nasty case of inguinal hernia, and because he didn't have any pain, the dad was like, he doesn't need surgery. Are there any long-term consequences or things that we need to educate our athletes about?
Yeah, real inguinal hernias won't go away on their own, and all the praying in the world won't make them go away. But you can delay, if they're not in a lot of pain, you can delay the therapy for it until they're off season, okay? And if you're a 95-year-old with a bad heart and had a stroke, you may not want surgery for it. But what we worry about is a couple things. That the intestine at some point will get caught in there, or that it'll continue to grow and get bigger. So if you see a hernia in an otherwise healthy young athlete, you can say at some point you're going to need surgical repair of this. Doesn't have to be done today, but sometime off season after you're done with football, baseball, but then you can have it repaired. Other questions at all? Yes, ma'am.
I've read a couple articles on this, and one of them in particular mentioned that there's a growth plate there, the insertion of the adductor, that doesn't close until early 20s to mid 20s. Have you run across that?
Yeah, it's not so much a growth plate because the bone's not supposed to grow there, but it's a attachment of the adductor to the pubic tubercle right there, and there it's a tendon basically. There is a growth plate in the pubic symphysis where it doesn't totally closed. Just like in women that are having children, that area can open up and then come back and close during pregnancy. The hormones will let it release so they can deliver and come back. In young men, I'm not sure how late it would be, but you can see it in 16, 18-year-olds. It might go up in their 20s. That area is not totally fused yet, so they can have some slippage there and pain there as well. But most of the time, the adductor where it attaches is a very firm, and a lot of people get worried, well, what are you, if you're cutting the adductor longus, is that going to cause a weakness or so? And the answer is no, because the adductor brevis and magnus and all those, and the muscle is still there and it attaches to the others. Sometimes if it's a big disattachment, you can suture it to one of the others, but releasing it there and then putting, what I do is I put steroids and long-acting pain medicine, Exparil or so, microsomal Marcaine, that gives them a few days of pain relief so they don't have to take any pain medicine. Other questions at all? Okay, thank you.
Thank you, Dr. Thank you. To follow up, Dr. Roland Ramirez is going to speak about the rehab. The first one of my sports hernias, I didn't know how to rehab. Didn't know where to start with or anything. Dr. Andrassy did it. So I went to Roland and said, hey, what do I do with this one? So I followed Roland's cookbook, and with that one, and the second one, and the third one, and they all came back in 6 weeks to play the whole year with no problems. So I really think what he guided me and what he's researched and done played a big role in getting those athletes back. So Roland Ramirez is the assistant athletic trainer of the year for the NFL Houston Texans.
You don't have to share that.
And also the athletic training staff of the year for the NFL. For Roland Ramirez.
Thank you. Thank you, guys. Can everybody hear me okay? All right. All right. How do I get this baby going? And, thank you for the invitation to speak here. I really appreciate the opportunity, to stand before you. And I'm going to focus a little bit on rehab. I know Dr. Andrassy spoke a lot about the anatomy and the surgery itself, but I'm going to try to focus on rehab itself. And I will preface by saying I apologize that there's going to be some redundancy, especially in those first slides that I have that you just saw in his talk, in Dr. Andrassy's talk. So I'll zip through those and we'll get to the fun stuff. I have a ton of videos. Hopefully those will work. But anyway, we'll get to that part of it and really focus on the rehab. So just talk to you a little bit about athletic pubalgia today. Here we go. A quick disclosure. I do have a relationship with DS2 Rehab Systems. I'm the owner and president of that. I was the inventor of the DS2 platform, dynamic stabilization and strengthening platform. So quick disclosure on that. So athletic pubalgia was first described way back when. Sorry, I keep getting in your way. I like to move. First described way back when as increasingly recognized as a cause of acute or chronic growing pain. Okay, typically occurs in young athletic males, usually present with a gradual onset, increased related growing soreness, can be disabling and can, quite frankly, just cause you to quit your sport. Most often occurs in sports that require sudden changes of direction, okay? Football, hockey, soccer, quick change of direction, twisting, turning, planning, cutting, you name it. So sports hernia, gross misnomer, right? It is far different from a traditional inguinal hernia. You just heard that a second ago. popularized by the media, now commonly used by the medical profession. Poorly understood, and the definition, etiology, and pathophysiology vary widely throughout the literature. Also known as sportsman's hernia, Gilmore's groin, core plate injuries. You saw a list of several other names: soccer groin, hockey groin, list goes on and on. Okay, medical community prefers the term athletic pubalgia, okay, for this type of injury. And it's a set of injuries, you saw this on a slide previously, set of injuries to the abdomen or the pelvic musculature, okay, that causes weakness of the posterior wall in the inguinal canal, may lead to a bulge, okay, or compression of nerves, usually the genitofemoral nerve. Okay, it's a strain or tear of any soft tissue, muscle, tendon, ligament as well in the lower ab or groin area. Commonly caused by hyperextension of the abdomen, right, or hyperabduction of the thigh. Okay, it's a common mechanism, likely from excessive or high repetition shear forces applied through the area, right? Poorly balanced hip adductors, abdominal walls, all the things that connect in that area. Okay, it could be one injury or it could be a combination of several injuries, and it leads to instability of the pubic joint. That is almost what defines solely this athletic pubalgia, as an instability of this pubic joint. All right, so as we know, as we heard, okay, complex anatomy, all sorts of variability in the presentation of this, non-specific nature of signs and symptoms make this diagnosis very challenging. Okay, you saw this slide previously. I'm not going to go in full detail, but we know rectus, we know obliques, we know transverse abdominis, we know the adductors, the hip musculature. Everything is pulling in different directions. If you have imbalances, asymmetries can lead to trouble. I think this slide was also shown or presented, again, showing you the different attachments, the different pull, right, of all these different muscles. Okay, we can have weakness in that posterior inguinal wall, a tear of the transverse abdominis, causing, just above the inguinal ligament, causing all sorts of issues there as well. So I'm going to zip through that. Okay, so what are the symptoms? So usually vague, unilateral or bilateral, lower abdominal pain, groin pain, usually above that inguinal ligament. Okay, dull, diffuse, it could be sharp, it could be shooting pain. Okay, it can also be burning. Pain can radiate towards the scrotum, the testicles, the perirectal area, inner thigh, and can cross midline even. Okay, usually occurs on exertion. In particular, all the sprinting, the cutting, the kicking, the twisting, the jumping, all the things that our athletes do, right? Okay, pain can last for varying periods of time. Okay, sometimes it's days, sometimes it's hours, days, weeks, sometimes can go on. You might be able to manage your athletes through a season or something with injections or whatever else, but eventually it might become so bad that they're going to need another intervention. So what's the exam like? Okay, tenderness, palpation at the pubic symphysis, groin area, pubic tubercle, no inguinal hernia, but tenderness and or dilation of the superficial ring. Okay, a positive direct stress test, which is basically palpation over superficial inguinal ring, with the patient lying supine. They actively perform a straight leg raise, increase pain with that. Okay, pain with coughing, sneezing, sprinting, kicking, sit-ups, leg lowering, resisted leg holds, and groin activation. All right, so I'm going to hush for a second. I'm just going to play this video. This is just a typical evaluation. I apologize. I'm going to speed through this evaluation, but we'll go from here. I hope it's muted. You never know what's going to happen in the training room, right? Uh-oh. It says QuickTime not available. Uh-oh. That's not good, man. I've got a ton of video. Uh-oh. Song and dance. Sorry. I have my computer here. I don't know if that helps or works. Bob, I have my Surface here also, if you want to hook that up. I guess while we're waiting for that to upload, I could talk a little bit about the evaluation. So basically going through this, so a guy comes in, I've had diffuse pain, I can perform everything, I can jump, I can play my position, but I'm having this lower abdominal pain, or I'm having this groin pain, this very vague pain. It usually, the history usually involves them feeling pain at the initial stage, and once they warm up, they feel a whole lot better, and then they're able to get through their practices, right? So probably everybody in this room has seen that that kind of exam or history. But going through this, so we'll start off with usually a partial sit-up, have them do that, see if they can perform that. Then I'll do a resisted partial sit-up. Then I'll get a leg lowering, or they'll perform a straight leg raise. They'll do one at a time, just a leg lowering one at a time. Okay, do resistance that way. I'll do it bilaterally. They'll raise their legs up. Okay, lower, nice and slow, nice and easy. And then we'll get into some hip flexion. Okay, resisted right shoulder to left knee type of movement, and then the opposite. Then we will go into we'll bring them over to the side, really get them into a stretched position, extended position off the side of the table. See if that any passive motion or movement there bothers them. Then I'll have them resist from that position. Okay, and then from there from there I'll test their adductors. Okay, basic butterfly squeeze, get them out for a little farther out, have them squeeze from there, get them in a straight leg position, have them performing in different positions there, also up diagonally. We'll have them do that as well. And then go into differential diagnosis of the hip. Okay, there are, whether it's a labral injury or some type of lesion in the hip, you always have to rule that out. So we're checking range of motion of the hip, flexion, extension, internal, external rotation. Okay, checking the muscles around that, and then from there, just our palpation and seeing what you find, what they feel, how much soreness they have. So. Sorry, guys. Any questions so far? I guess we can knock that out. Anything so far that you've seen as far as the exam that I've explained? Anything? And you guys making it easy or hard? I'm not really sure.
How often is it just entrapment of those nerves in that area? Frequent, not?
In my experience or our experience, it's not very frequent. I think post-surgically, we've had some symptoms that have manifested that way. You really have to appreciate. Sometimes you don't appreciate the magnitude of the injuries and all the bleeding and inflammation that they have there. So you can get a lot of nerve-related symptoms that way. But it's usually we haven't seen really an entrapment of it. In our setting, the injuries are usually pretty traumatic, and so we've had grade 3 adductors that rip straight off, and we of course we know that we're going to have to manage them surgically, and there have been some cases where they have some nerve related issues after that, but not usually before. It's in our setting, it's usually pretty traumatic, and they feel it right away. They make a cut or they make a kick, whatever else, and they feel it right away. So good question though. Anything else? Any other questions?
Is there anything in your warm months? Did y'all start incorporating and notice a reduction in it?
You know, not really. I mean, we have a pretty thorough warm up. We have a pretty thorough movement prep, corrective exercise program that we take all our guys through. And, you know, again, it's usually pretty traumatic in the nature of how they happen. And, but, you know, overuse over time, you know, if they have micro tears and they're having issues and you're able to manage them through the season, and then eventually it just, you can make one big move and there it goes, you know. We do. So we do some, not that we've been able to find. The question is if we've done any functional movement screening, and we do, but we haven't really been able to find any kind of correlation. For the most part, our guys, about half of them move well and the other half don't move well, just like your athletes. But we haven't been able to see a correlation, but it's usually pretty traumatic. When it happens, it happens. So, you want my surface, Bob? Yes, sir. Yeah, no, that's a great question. And you know, small little cup, sorry. That scared me. I was like, whoa, I'm not going to pay for that. No, that's, yeah, community cup. There you go. Communion cup. So it's a great question. You know, I've always wondered that myself, and I think you know, over the last couple of decades with the increased emphasis of, you know, core work and all this core exercise, you know, to me, yes, core is very important. And I think we all agree on that. But when you're sitting there and doing all sorts of leg raises and straight leg raises this way and long lever type of exercises, and you do it over and over and over again, and sometimes overdoing it and doing it for hours, I think you cause all these types of micro tears and tendonitis and overuse injuries, and they lead to tendinosis and then scarring of the tendons. And then you have some of these, you know, asymmetries and imbalances. And when you have athletes at a high level or even high school or collegiate, and they're really good athletes, they're still having to plant and cut and twist and react. And when all that adds up and those imbalances are there, then something's going to give. And usually, just like any other injury, I think with if towards the end of a game, if you're tired, whether it's a knee or whether it's your core, I think that those imbalances, all that stuff is going to shine through and can really lead to those injuries. So I mean, I'm right there with you. I think that it has a lot to do with it and factors into these injuries. But yes, sir. Right. Absolutely. And if we can get this baby up and going, you'll be able to see the rehab. And I tried to place a lot of videos in there that kind of guide you into that progression. Starting off really slow, controlled, very easy, very short. I guess not really extending the tissue very much. And then you get into more elongation of the tissues, really extending their legs out, really extending their arms, really extending the fascia and all the muscles that are, you know, attach at the core, across the core, and then eventually into a lot more functional exercises and a little more challenging stuff. So once we get this up and going, hopefully I can show you that and we can kind of walk through that. But it definitely, it plays a factor in it, and start from short lever to long lever type of exercises towards the end. So, anything else? It looks like it's coming up.
I guess from diagnosis to, you know, return to play, like they're taking some reps and stuff. what's the kind of like an average span of time
Right.
that these athletes recovered, so I can tell my coaches, hey,
Right.
this athlete, I don't know, who they played with,
Sure.
you know, with all things being thrown at them,
Right.
dietitian, everything, you know, that's how kind of like average.
Right. No, and usually it's 6 weeks. The protocol we use is usually 6 weeks, and it's usually right on. Now, depending on the severity of the injury and the involvement of the surgery, that could take a little longer, but usually not anything less than 6 weeks. But they're the very next day they're walking around, they're feeling pretty good. Going up and downstairs might be a little challenging, but as a week goes by, 2 weeks go by, incisions are healed, they're in the pool, they're starting to move around a little better. 3 weeks, they're feeling really good. They're performing step-ups and lunges and those kind of things. It may not look pretty at first. And then once they get into 4 weeks, 5 weeks, then they're starting to get on the field. They're starting to run and then get into some change of direction. It's going to be slow and controlled at first, obviously. And then once 5 and 6 weeks, you can actually push them pretty hard and they're feeling pretty good.
So you're saying post-surgical?
Post-surgical, right. You need me? You kicking me out?
Everybody turn around.
If you can turn around.
Oh, no, man. Really?
Yeah, sorry.
Bob. Okay. Well, can we start that over?
Yeah.
This is awesome. All right, so I'm giving the thumbs up there. It looks. Glad I changed my contacts this morning. All right, so a little partial sit up, a little resistance that way. We're doing the straight leg raise, then we're gonna slow and controlled lowering there. Okay, we'll test the other leg. Oh, I'm gonna do resistance there first. Different angles. All right, muscle testing there. And then we're doing bilateral. Raise that up. Does it cause any pain? Lowering. Does that cause any pain or discomfort? Okay, and then resisting there. Resisting a different position. What? Yes, ma'am. Mm-hmm. And then I'll just get them to the straight hip flexion. Okay, and this is where I do the opposite shoulder and resisting on the knee or hip flexion as well. Then I think I get them off to the side. Yep. Get them off to the side. Really get them in an extended position. Then have them flex their hip from there. Having them flex there. And then we'll go into the adductors. So bent knee or butterfly position. Okay, I'll get them off to the side, have them resist there, resisted adduction, bent knee position. Then I'll take them through range of motion, checking their range of motion of that left hip. I'll have them also manual muscle test, internal, external rotation of the hip. Also take them through a Faber's test, just ruling out any hip pathology. And checking Faber's there. And then here's more of the long lever hip adduction, right at neutral, then out at 45, and then up and diagonal. So here's the direct stress test that we were talking about. So just palpation right at that lower abdominal area, inguinal area, and having them perform a straight leg raise. And then just checking for palpation, checking the adductors, checking the pectineus. Okay, hip flexors as well, having them resist there. What does that muscle feel like? Do you feel it firing? Okay, just a pelvic exam there, basically. All right, and that's the end of that video. So I guess we just need to find out if I can read that, if it's gonna. Oh, nice. I guess the videos we're gonna have to do there though. Can I proceed, Bob? Or okay. So a little bit of non-operative treatment. Okay, rest, NSAIDs, injections that we talked about. Okay, we can try some rehab, see if that helps, see if they're able to manage it, if you're able to manage their pain and discomfort. Okay, sorry guys, I keep getting in the way. If unsuccessful or diagnostic uncertainty exists, okay, then further investigation is recommended to determine the actual cause of this, right, or confirm a core injury. Refer to an orthopedist or a general surgeon that is familiar with this and has an interest in athletic pubalgia, so that other growing pain can be ruled out or symptoms persist despite all the non-operative treatment or rehab that you've performed. Okay, operative reinforcement of the posterior wall. Okay, that's the basic thing that you have to do, open or laparoscopically. Okay, open repair consists of all sorts of different modified techniques or procedures. Okay, classic Bhojani repair, Lincolnstein repair, minimal repair techniques, epimesiotomy, reattachment of avulsed tissues. I'm not even going to begin to try to explain some of that. I'm going to stick to the rehab part of it. As far as the laparoscopic repair, okay, involves reinforcement with mesh, either total extraperitoneal or preperitoneal mesh repair. Okay, as far as the open surgical procedure, you have a pelvic floor repair, okay? And they can consist of reattachment of the rectus abdominis to the pubis, okay? It can also be an adductor release, which is basically a release of the fascia only, or an epimesiotomy, okay? A lot of, in our experience and what we've dealt with in most cases, have been a grade 3 adductor strain or a tear off of the pubic bone, okay? And then they reattach it, the surgeon reattaches that over to the pectineus and to that common tendon there up into the pelvis. Okay, so that's been a very common one that we've seen and worked with. As far as laparoscopic surgery, not recommended since it fails to address the adductor symptoms. Okay, tension, it's a tension-free mesh that usually doesn't stabilize the pelvis very well, but it plays in a role in the treatment of true traditional inguinal hernias. More so than the athletic pubalgia. Okay, as far as post-op care, wound care, we all know it's huge. You don't want an infection, right? We have to make sure that we take care of those things. Leave the steri-strips intact, okay, until they fall off. They might have a drain intact, okay, so we have to make sure we're draining that, taking proper care of the portal hole. Okay, stiffness under each incision is completely normal. They're going to feel just this big bulge here around this area. There's a lot of bleeding, a lot of stiffness there. That is completely normal. It's going to flatten out over the next several weeks and months. Okay, bruising in the lower abdomen and the groin down into the thigh, completely normal. Okay, be aware of a hematoma under the incision. Anything draining excessively, we got to be aware of that. And then you may develop, we touched on this earlier, we may develop other neurological symptoms such as numbness, tingling, nerve-related pain, excruciating pain down into the pelvic floor. All right, so as far as rehab, we can expect a full return to activity in between 6 and 12 weeks. May take longer than that, may take a little less. Okay, week 1, usually ADLs, no lifting, no Valsalva. Okay, walk 1 mile a day. Okay, increase is tolerated. Can initiate general resistive adduction exercises, so the simple pillow squeezes, ball squeezes, we can perform that week 1, no problem. Light core exercises, so your pelvic tilts, transverse abdominis activation, your bridging, very simple, very basic exercises. glute activation exercises, okay, hip abduction, whether it's clamshells, whether it's supine, okay, we've been there, done that. Week 2, okay, general soft tissue massage of the adductor. We usually try to stay away from the incisions, okay? Performing soft tissue only around the incisions. You don't want to get right on it. Don't want to open those suckers up, okay? So around the incisions only. Progress core exercises is tolerated. Advance your glute activation exercises, the general stretching of the hamstrings and quads. You just gotta protect the limbs. You gotta really protect the involved side, okay? Help them to feel comfortable. The last thing they want is for you to be stretching them out, and then you bring them into, you know, an abducted position, and they feel like you're going to drop their leg. So we have to make sure that we make them comfortable and really allow them to trust us with those limbs. And then progress to elliptical stairmaster at that end of that week 2, and we can go from there. We can initiate pull exercises. Okay, please make sure that the incisions are healed. If there's even any kind of question, just don't do it. Just wait a couple more days, wait another week. Just, it's not even worth the risk. You don't want that to open. I know there's Tegaderm and there's all sorts of other little things that we can place on the wounds, and they say that it keeps it dry. Just don't even risk it. Wait for those suckers to close, and then go from there, okay? And then progressive resistive exercises. So now we're getting into this week 3. They're feeling pretty good. So we're performing squats, all our step-ups, our lunges, okay? General stretching again. Increasing that, light plyometrics and jogging if it's appropriate. You might get them in the Alter G. You might be jogging in the pool at this time. And then adding sport-specific activities is tolerated. They might be able to tolerate a little ladder out on the field or on the turf, okay? Week 4, progressing, again, their exercises, okay? Advanced pull exercises, leg swings, karaoke, lateral shuffling, okay? Advanced straight-ahead field running. By week 4, we're feeling pretty good. And getting them on the field, okay? Transition to lifting in the weight room. And introducing light change of direction agility exercises. They might start weaves, they might start zigzags, might start their cone stuff if that's appropriate. Week 5, they're advancing again, okay? Pushing it a little harder, elongating those muscles, really getting into their rehab, and getting functional with that, progressing their run, their change of direction, adding the position-specific work, as we mentioned. And then week six, hopefully they're getting back at it, okay? And returning to limited or full practice at that time. And of course, it's very important to establish a long-term core maintenance program, right? We all know that. All right, so video time. Maybe. So should I just go through this? I don't. Oh, look, it's playing over there. Shoot. This was going to be the fun stuff right here, man. Will it play back there? We can just turn it. All right, so if you'll just turn that way, and you can see, so on the left, we're doing it's kind of a squat kick, glute exercise. Okay, there's a band around his knees, band around his ankles, stabilizing on one leg, and firing the glute with the other, with both really, but actively moving one leg. You can go to the one on the right. And then this is just a simple step up. Okay, kettlebell on one side, really activating their core. The leg that's moving is the leg that's swinging in the air, or the arm that's holding, just to stabilize. All right, we can go to the next one. So on the left, we have just a simple, slow, and controlled lateral step up. Okay, weight is around his neck. Important, just early, make sure you cue and correct them early. Okay, really try to refine the skills and teach them the proper movement patterns as they're going through it. You can go with the one on the right. Oh, so this is different over here. So the one on the right is just an anti-rotational press, okay, with just a little adductor squeeze. This one's going a lot faster over here. We'll stick to those, I guess, over there. All right, so on the left, this is called Rose wall slides. And so mini band around their ankles. So heel is against the wall. Okay, toe is pointed straight ahead or slightly down. Okay, butt's against the wall, shoulders against the wall. Okay, and they're having to slide or abduct that leg. Really good glute work with this. Okay, on the right, feet are together, just a different variety with our bridging. Okay, glute med, great stabilization. We have a band around their knees, and they're performing just simple oscillations with a med ball overhead. We can go to the next one. All right, so the next one's like this up here. So the one on the left, he's just performing a step up, forward step up, a little more dynamic, just having a Dynamax ball, just raising it up above his head. We can go to the one on the right. And then this is a simple half kneel to single leg stance exercise that we have with the kettlebell. Just very good stability work. Get some good strengthening work and stability work up at the top. All right, we can keep going. I've been up here an hour already, I think. All right, so now we're going to go into a resistive kind of, quadruped, alternating arm and leg extension. And you can't hardly see it there, but there's a band around his feet here and around his hands. Okay, so as he's extending one arm, it's resisting and the other leg as well. Okay, the one on the right is hip adduction squeeze. He's standing on a Bosu ball. He's got the free motion machine or any kind of pulley system or bands, and he's performing just a simple lat pull or arm or shoulder extension while he's stabilizing. All right, we can go to. It's one band, actually. It's one long band, so it's around this foot and then both hands. So as I stabilize, I extend out, and then I'll switch feet, and I still have it on both hands, and I extend out and then extend or flex the other shoulder. Does that make sense? Yeah. So you can get one long piece of TheraBand and do the same thing. Okay. Okay. Now this next one is just chop and lift. Okay. Again, a pulley system, bands. If you go back, so you can see the chop and lift. This way he's just doing a little adduction squeeze. Okay. If you'll go to the next one, I think we're just doing a lift portion of this. Okay. And then we'll keep going. All right. So this is just a modified pistol squat. Okay. That's a pretty good little squat. This is a box squat. On the right, we're just general strengthening. We've got a BFR unit, okay, blood flow restriction unit and tourniquet. And I'm not really, for time's sake, I'm not going to get into any of that, but it's been shown in a lot of research for muscle hypertrophy, okay, protein synthesis, and Geoff Kaplan, who is going to come up after this, is going to talk a lot more about that. But we have been using it a little under 2 years, and it's been remarkable. So we'll go to the next one. All right, so here's we're going to get into a little more elongation of the tissues, okay? So with that, we have a big stability ball, okay? And now we're getting into hip extension and arm flexion. So tissue's feeling pretty good. You might just have to do a modified version and go down halfway. Okay, we'll go on the right. This one on the right, okay, no stability ball, but we have a med ball going overhead. Okay, alternating that hip extension as we move the ball overhead. Okay, we'll go to the next one. All right, so this is just an alternating knee extension or a leg kick. Okay, so he's holding a kettlebell overhead. He's got a band over his knees, and he's kicking out, okay? Next one on the right is sort of an anti-rotation exercise where he's holding it just above, okay? He's sitting lateral to that pulley system, and he's just performing, you know, hip flexion and extension. And then we switch sides. Okay, this one here, now we're getting a little heavier, okay, instead of a light med ball. So we have a kettlebell overhead. He's performing a leg lowering exercise. Okay, and then we can go to the one on the right. Now we're getting a little more dynamic. So now kettlebell is moving at the same time that the opposite leg is moving. We're going straight down, we're going at a diagonal, and then we'll go out to 90 degrees. Okay, we'll go to the next one. So this one here, he's stabilizing. So his hands on a P ball, feet are on a Bosu ball. He's just performing oscillations. So up, down, side to side. Okay, circles one way, clockwise, counterclockwise. You can do the alphabet, whatever you want to do there. Okay, on the right, he, I think, is doing an anti-rotation again. Anti-rotation again, feet close together. He's got a band around his knees. He's on a Versadisc ball. Okay, he comes up, he abducts his hips, and then comes right back while he's maintaining stability of his upper body. Okay, we'll get him on the Alter G. So this is that week 3 period where we're feeling all right about things. Okay, we're progressing with that. We're progressing with our general strengthening. Okay, on the right, this is just a reverse lunge. We call it a kettlebell reverse lunge to single leg stance. Great exercise as far as reaching back into that lunge position and then coming right up into a single leg stance. Okay, keep going. So now we're doing what we call 3-way step-ups. Okay, so we're going forward. He has a kettlebell in the left hand in this catch position. Then we're going to go lateral kettlebell. Yep, and then we're going to go into a rotational step up. Okay, so they're facing one way. They open up 90 degrees and go up. Okay, on the right, this is called a med ball lateral lunge, like a lateral lunge med ball drop to a single leg stance. So he goes down, he comes right back up into a single leg stance. So a lot of stability work that we do with our guys. Okay, we'll go to the next slide, please. Here's just a reverse lunge. You know, obviously the sliding component to it. So very good, and also resistance on the way up. Okay, you can do that reverse lunge, the lateral lunge. On the right, you see some glute work. We have bands around his knees and around his ankles, and so just sliding to different positions, different dots on the board. Okay, we'll go to the next one. So now he's in a split squat stance, performing oscillations with the free motion machine. Okay, on the right, we're just doing our mountain climbers. You can do the knee tucks. Actually, this is knee tucks, or you can do alternating the mountain climbers. You can do the jackknives or the hip hikes. There's different terms for that. Okay, we'll go to the next one. These are just some pictures, no video. These are just pictures, but one elbow's on a foam roller, his feet are on a foam roller, and he's holding a kettlebell up over his head. Pretty tough exercise. And then the other one is just toes on a foam roller, elbows on a foam roll, and pretty tough, especially the one on the left. All right, we'll keep going. All right, we're now getting a little more explosive, so we're starting our plyometric. We're doing some chop lift. So I'm bouncing the ball to him. He's chopping down on the left. And then on the right, I'm tossing it kind of overhead. He's performing the lift component of that exercise. All right, we'll go to the next thing. This is just some manual perturbations. Okay, he's in a split squat stance. He's got a ball in between his knees. We're squeezing there. I'm manually challenging him as he tries to stay still. On the right, he's in a supine position, in that bridge position. Again, hip adduction with a ball. Okay, I'm trying to force him into different directions with his upper body and his lower body. Okay, then I get over by his hips after he's doing that. I get over by his hips and really try to move him or manipulate him that way, and challenge him that way. So we'll go to the next thing. And then we're starting our side-to-side band, getting functional here around that 3-4 week, into that 3rd week, 4th week. We're doing some side-to-side band hops, okay, med ball activities. We'll go to the one on the right. We're starting some forward and back diagonal hops. Really getting explosive. Okay, we'll go to the next slide, please. Let's see. So just some hurdle hops. Okay, then we're doing some box jumps. These are just some basic hops. Okay, that's usually a good starting point. Okay, then we'll go to the next thing. And then we'll do some drops. Okay, we'll drop down and then bounce right back up. Well, we might move laterally. We might move in a diagonal position. The one on the right, you can tell he's feeling pretty good about himself at this stage. He does a little jiggy. There you go. A little dance there, so he's feeling pretty good. All right. And then we'll start on the left here. We're doing a little more rotational hop. Okay, opening up, doing a little rotation there. And then on the right, we're just, again, getting a little faster with our speed. Getting some hurdle stepping in there. Eventually, double leg hops, single leg hops, those kind of things. And then, let's see, we're doing some step up jumps in this one. Yep. And then on the field, we're eventually getting to smell the grass there and get on the field. Okay. And then that's a whole another progression in itself, right? So. All right, so back to this. There you go. Sorry about that, guys. But so these injuries can emerge as one of the largest categories of accounting for loss of playing time. Okay, tenfold increase in the number of athletes seen over a 20-year period. Okay, overuse, one-sport athletes, repetitive training. Okay, those are all good questions if you're asking yourself that. Okay, they rarely respond to non-operative treatment. You might be able to manage your athletes through a season or two. Eventually, you might have to operate, though, okay, if it becomes worse. And then, so surgical repair will allow greater than 95% of athletes to return to sport within 10 weeks. Okay, that's what the literature says. That's a pretty good number. And so surgery is a good outcome if you have to go that route. Okay, surgical procedures include various types of reattachments, okay, or releases of soft tissues that attach or cross the pubic symphysis. And the increased knowledge base of these injuries has resulted in 18 or 19 different distinct syndromes that have been identified, 121 different combinations of procedures. Okay, 17 musculoskeletal structures can be involved. Okay, have nothing to do with true inguinal hernias. We talked about that. Involve a variety of injuries that can affect the stability of the pubic joint. We talked about that as well. The history and the physical exam is vital in these with these injuries. Okay, so make sure you're listening well, listening to their symptoms. Also, the MRI images nowadays, the oblique images that you're able to get, the advancement of the MRI really can play a big part in diagnosing these injuries. And you need to rule out other hip pathology. Over 15% of patients with MRI findings of athletic pubalgia also have evidence of hip pathology. So different cam lesions or labral tears, so on and so forth can be found as well. Just to sum it up, okay, numerous articles on this injury in the literature, okay? It's okay to dive into the literature and then walk away feeling like you haven't learned a thing, like you're still confused. That's very normal. It is an injury that is hard to identify and it's been hard to diagnose over the years, and it still is very challenging, but the history is very important with that, okay? And we need to modify our rehab and core stability programs that relate to the procedure performed, okay? Specifically what was performed and the sport played and the new pathophysiological understandings of this injury, okay? And we just need to make sure that the final stages of rehab are appropriate, okay? And to minimize the risk of re-injury and maximize the safety for them to improve the functional outcomes in our athletes. We need to make sure that we're doing our part and throwing position-specific work at them or challenging them enough so that we can minimize that risk of re-injury once they return to the field, okay? So, a couple references, and sorry for the long presentation. Any other questions? I really appreciate your time. There's email and some other info there, but yes, ma'am.
Those videos and everything you saw can cross-train us on any number of injuries.
Right. Right.
Minimal amount of equipment change. Is there any way we can access those videos so that I can show them to some coaches for some off-season work? Or
Right. I don't mind sharing them with you. If you want to shoot me an email, and that goes for anybody. If you want to shoot me an email, feel free to. Oh, it was up there. I don't have them posted anywhere. Classified information. No, I'm just joking. But a lot of it is stuff that you've seen or done, you know, and maybe you've seen some new things. But Roland Ramirez, Ramirez, there it is, at HoustonTexans.com. If you want to reach out to me, and if you, yeah, you can email Bob as well. Okay, if you're having trouble getting a hold of me, but feel free to email me. And if you mention, you know, certain videos that you're wanting to see, I'll be glad to share them with you. So, anybody else?
I apologize, Roland.
No, it's okay. Thanks a lot, guys. I really appreciate it.
Roland and I worked all last week trying to make sure it was all hooked up, working on my computer, and then my computer doesn't work.
Where's the sync go?
Your side. This is live already.
Okay.
Our next presenter is Geoff Kaplan, the head athletic trainer, director of sports medicine for the Houston Texans. And it was kind of his brainchild to start off with blood flow restriction therapy. They use it on 60, 70%. Rough guess?
Yep, a lot of guys.
60 or 70% of their rehab and patients downtown. He's kind of got it down to a science. So I've asked him to speak on blood flow restriction.
Thanks, Bob. I appreciate Bob having this course today on a day we don't have a mini camp or an OTA. So Roland and I can be here and show you guys some of the things we're doing. So kind of how this all got started is a year and a half ago, 2 years ago, we had a highly drafted player on the first game of the season get hurt. Bad injury, meniscus tear, microfracture, whole 9 yards. So when we did surgery, Dr. Lowe was worried about disuse atrophy and weakness, and what's the latest and greatest things that we could do to retard atrophy. He got us hooked up through Stefania Bell. Stefania Bell is an ESPN commentator and a physical therapist who works with ESPN and does outside the lines and things like that. And she was doing a special for Veterans Day at the at Brooke Army Medical Center, the Center for Intrepid Johnny Owens in San Antonio. He's done a ton of research on BFR, and they got us hooked up. And Johnny taught us about BFR, and we started using BFR a year and a half ago. We started with one machine a year and a half ago, and now we have 4 units. We started doing it with one player. Now, I would say 90% of our players that do rehab do some sort of BFR training. So what is blood flow restriction? It utilizes a special surgical tourniquet. There are some important terms that you need to use and be aware of. The limb occlusion pressure. Limb occlusion pressure is when you've cut off all venous outflow and most of arterial inflow. Every person comes with a personal tourniquet pressure, a PTP, and the tourniquets have a Doppler in them. So we measure every athlete's personal tourniquet pressure, and then we'll use 50% of the limb occlusion pressure for upper extremity injuries and 80% of the limb occlusion pressure for lower extremity injuries. Using these numbers creates an optimal environment to create a chemical reaction or a physiological reaction in the limb, and it avoids venous congestion. So one of the major things that we're trying to accomplish is hypertrophy. We are not accomplishing hyperplasia. This has not been proven in human models. It's been proven in animal models that you can produce hyperplasia, but not in human models. So we are producing hypertrophy. We are inducing an ischemic and a hypoxic environment. And the way we induce the ischemic and a hypoxic environment is creating a mechanical tension around the limb with a tourniquet. Mechanical tension causes muscle damage. It increases a localized systemic hormone response. It increases cell swelling. It increases nitric oxygen production, which releases calcium, which causes muscle anabolism. It increases IGF, insulin growth factor, which increases protein synthesis. It increases muscle fiber recruitment. We're going to go through all these because for me, it was really important to understand the science why BFR works. And if I understood the science why BFR works, I was all in. So hypertrophy in 2004, Takahara did a paper, and he did he measured exercise using 20% of the 1 rep max. It was a lower extremity study. He controlled BFR versus the control group. He used knee extension. Used a knee extension machine in an 8-week study. He measured cross-sectional area and strength of knee extensors. The BFR group versus the control group had a 10.3% increase in cross-sectional area after 8 weeks and had a 9.3% increase in strength compared to the control group. There was also a significant rise in HGH, human growth hormone, in the BFR group. There was no change in HGH in the control group. Hormones. While using the BFR, you have a strong anabolic hormone response post-exercise. You increase growth hormone and mechanical growth factor. Mechanical growth factor starts local repair of damaged tissue, which is responsible for hypertrophy. We start up an anabolic cascade, which mediates muscle protein synthesis. We turn on mTOR, and we activate the mitogen-activated protein kinase. All this increased protein synthesis. All this increased bioavailability of the cells. All this increases the cell's ability to produce more energy and heal and get stronger. Satellite cell activation and proliferation. Satellite cells are stem cells. We have an increase in satellite cell activation and proliferation during blood flow restriction. Increase in cell swelling. You have an increase in the intracellular hydration, increase in protein synthesis. You have a decrease in blood cell destruction, bone cell destruction, and decrease in muscle fiber destruction. Because of this, you don't have any post-exercise soreness. There is no DOMS, no delayed onset muscle soreness. Nitric oxide is increased. With increase in nitric oxide, it stimulates satellite cell activation and proliferation. We also have activation of the sarcoplasmic reticulum, which increases calcium release in the cell, increases the mTOR activation, and all this cascade increases protein synthesis. Heat shock proteins. Heat shock proteins typically transform from locating and assembling protein to maintaining cellular homeostasis. Heat shock proteins limit oxidative damage, which decreases or limits the amount of soreness you have post-exercise, and it increases hypertrophic adaptations. Muscle fiber recruitment. BFR leads to a decreased oxygen availability. All that makes sense. We're putting a big tourniquet around the limb. Decreased oxygen availability, which increases which causes a high metabolic accumulation. The slow twitch muscle fibers are exhausted. Then you have increased stimulation of the group 3 and group afferents to the brain. You have inhibition of the big alpha motor neurons, which increases fast twitch muscle fiber recruitment to maintain conduction. So the metabolite theory, muscle activation, BFR utilizes the size principle. We have increased workload, which leads to recruitment of large muscle units, the fast twitch muscles. BFR leads to decreased oxygen availability, which leads to increased metabolic accumulation of lactate. We all can understand that. Increased fiber recruitment, an increase in EMG activity. Yasuda in 2014 did a study, an upper extremity study, where he used Theraban for biceps and triceps, and he did BFR versus the control group. He immediately tested about 1 hour after BFR. Triceps had a 46% increase in EMG activity. Biceps had a 69% increase in EMG activity compared to the control groups. The metabolite theory, increase in HGH, human growth hormone. We have an increase in lactate, increase in hydrogen ions, which causes an increased growth hormone release. Takahara in 2000 did a lower extremity study. He measured plasma HGH, exercise versus BFR, and then exercise and BFR combined. He did 10 minutes of low intensity exercise. There was a 290% increase in growth hormone compared to baseline when compared to exercise alone. There was a 170% growth hormone, 170% increase in growth hormone compared to high intensity training. Well, you'll say, hey, Cap, I can do high intensity training and get a similar result. You can't do high intensity training immediately after surgery. You can't do high intensity training during early stages of rehab process. You can't do high intensity training when players have a significant chondral lesion. You can't do high intensity training when someone's coming off microfracture. You can't do high intensity training, so forth and so on. This is how we fool the body. This is how we fool the body during rehab. We're fooling the body thinking it's doing high intensity training, but you're doing low level exercises. Autocrine actions. There's multiple autocrine actions that are going on during using BFR. There's a decrease in myostatin expression, an increase in muscle mass and strength. Myostatin is what breaks down muscle. So you have a decrease in myostatin expression. In the FOXO, you have a decrease in FOXO expression, which is a decrease in response for muscle atrophy. So you have an increase in potential hypertrophy. So by decreasing myostatin expression and decreasing the FOXO expression, we're decreasing the ability, or we're decreasing hypertrophy, we're decreasing muscle atrophy, and we're increasing the environment for hypertrophy. Paracrine reactions. So these are how one cell affects another cell. Satellite cells are muscle-specific stem cells responsible for regeneration. Using BFR, you have an increase in stem cells, an increase in satellite cells, and you also have an increase in the number of mononuclei per muscle fiber. So instead of each muscle fiber having one nucleus, they have 2, 3, 4, 5, 6 nucleus per muscle fiber. More nucleus, more ATP, more energy to the muscle. IGF in satellite cells. IGF is insulin-like growth factor, increases during BFR. You have an anabolic effect. As our anabolic effects are increased with the increase in mechanical load, you have strength gains. Caddy in 2000 did a study of low-intensity exercise, and he did a lower extremity study. He measured knee extensors with BFR versus the control. With BF, and then it was a 10-day study. What he did is he measured the increase in stem cells, the satellite cells, halfway through the study, 3 days post-study, and 10 days post-study. With BFR, there was a 280% increase in satellite muscle stem cells mid-study, a 250% increase 3 days post-study, and 140% increase 10 days post-study versus the control group. Nutrition. Nutrition is very important while you're using the BFR. It's important to ingest 20 to 40 grams of protein immediately after, within 20 minutes of the BFR, and then every 4 hours subsequently. It is recommended that you use whey protein versus soy protein. Whey protein has more amino acids, a higher leucine content, and muscle protein synthesis has been proven that is greater with whey protein versus soy protein. Bone healing. There's a lot of cool research going on right now with bone healing and using the BFR. There's an increase in HGH and growth hormone, increase in IGF-1, increase in the interstitial fluid flow. Interstitial fluid flow increases during weight bearing. A lot of time with acute fractures, you can't actively weight bear. This is a way to fool the body and have increased fluid flow, increase healing response while using the BFR in bone healing, an increase in VEGF. In 2006, there was a walking study done, BFR versus control. It was a 3-week study where they measured plasma BAP, which stands for bone alkaline phosphate. There was an increase in osteoblastic activity markers, no increase in the control group versus BFR, and there was a decrease while using BFR in bone reabsorption markers. So we're getting an increase in osteoblastic activity, increase in bone formation. The acute phase of rehab. A lot of times you're non-weight bearing, you're immobilized. We're trying to mitigate disuse atrophy, increase neuromuscular recruitment, increase a systemic response, increase natural HGH levels. So using the BFR in the acute stage, you're getting increase in HGH levels and increase that big acidic environment, which causes all these metabolic cascades we've talked about. The subacute phase, we slowly add mechanical tension. You can bike or walk at low intensities, will increase strength, increase hypertrophy, showing an increased VO2 max, increase time to exhaustion, and increase in cross-sectional area. So those are all the benefits that we're getting out of BFR in the subacute phase. Some endurance training, some endurance research that's out there right now. There's an increase or change in VO2 max secondary to BFR in order to maintain cardiac output. There's a decrease in stroke volume and an increase in heart rate. Increase in muscle mass will also shift the VO2, will increase VO2 max due to an increase in metabolically active muscle tissue from inactive adipose tissue. Increase in myocyte count increases peripherally the VO2 capability due to increased mitochondrial count. So you're getting the increased mitochondria because you're getting the increased myonuclei in the muscle fibers. The loading phase of rehab. So we use typically 20 to 30% of 1 RM increase to get increased strength and increased hypertrophy. Our sets are typically 30 reps for the first set. Then we go subsequently 3 sets of 15 reps. It takes about 6.5, 7 minutes average. You want to build up the metabolites when the cuff is inflated. You leave the cuff inflated during the exercise periods and during the rest periods. So there's some research out there now that shows the effects of proximal gains. We have used the upper extremity cuff for rotator cuff injuries, for labral repairs. We put it high on the thigh, and we get increase in glute function and hypertrophy of the glute muscles. And here's a study, Abe in 2005, did 20% of the 1 RM max for a lower extremity study. He did squat and leg curl exercises, BFR versus control, and he used 3 sets of 15, 2 times a day for 6 weeks with 4-hour rest in between the exercise sessions. He had a 17% increase in squat strength using BFR and a 23% increase in leg curl strength using BFR. Exercise prescription, our training frequency, low lows associated with BFR does not produce lasting muscle damage. It can be done daily. Some research shows 2 times a day. Largest effect is seen within 2 to 3 days per week. Our exercise prescription is we do strength training with the BFR Monday, Wednesday, Fridays. We do exercise endurance training on a stationary bike or stationary piece of equipment Tuesdays and Thursdays. Longer durations have the largest effect size. Using the BFR 10 weeks or longer gets the same or similar results as high-intensity training program. Hypertrophy is seen earlier with BFR training than with high-intensity training programs. Hypertrophy is seen in as little as 2 weeks using BFR. Exercise prescriptions or rest periods. 30-second rest period have been shown to have the largest effect size. The tourniquet stays inflated during the rest period to capture and trap the metabolites. Exercise prescription and training intensity. We use loads typically of around 30%. When you're doing cardiovascular training, you want to use loads between 15 and 30% of your VO2 max. It has the largest training effect. Bike and walking usually fall below 15 to 30% of your VO2 max. Response to bike and walking with BFR is significantly higher than controls with the same intensity levels. So what type of tourniquet do we use? We use a Delphi tourniquet. It is the same tourniquet they use in the OR. It has 225 patents. It's the only medically registered tourniquet made for BFR training. It has a built-in Doppler, so you can measure the personal tourniquet pressure and the limb occlusion pressure. Cuffs are follow safety practice guidelines. The cuffs are tapered to match the limb shape. They're wide to avoid potential nerve injury, and they have different lengths to accommodate different limb sizes. Some cuff application procedures. It's important to inspect the equipment. Limb protection, application should be on the most proximal portion of the upper arm or thigh. The cuff port should always be on the outside lateral aspect. Contraindications. Contraindications, open fracture wounds, diabetes, severe high blood pressure, peripheral artery disease, so forth and so on. You can read it in your handout. Sickle cell disease. Sickle cell trait is a caution. We do it with players that have sickle cell trait, and we haven't had any issues as of today. Thrombus formation. A lot of people ask me all the time, are you worried about blood clots? Are you worried about blood clots post-op? Are you worried about blood clots during the rehab process? The answer is no, because there's an increase in fibrinolytic activity with BFR. Fibrinolytic is an anti-clotting factor. So you're increasing the blood's ability not to clot. So it actually decreases your chance of blood clots. There's been studies done by Johnny Owens, and he did pre and post training ultrasounds to assess for potential clot formation. And as of today, all of his work has showed no patients have demonstrated any signs of thrombus formation. An acute bout of BFR significantly increased fibrinolytic proteins and no change in thrombus markers. To just go a little bit farther and not worry about blood clots. Scope of practice in the state of Texas, physical therapists, athletic trainers, occupational therapists, doctors of chiropractic care are all allowed to use tourniquets. Physical therapists is within the scope of practice, currently working on a consensus statement. Athletic trainers are within the scope of practice under the supervision of the physician that you work under. Johnny Owens has been a great source of knowledge for us. He's also offers multiple continuing education courses across the country and across the state of Texas to get certified in using BFR. And his website is owensrecoveryscience.com. It's a great resource for tons of things. BFR, the courses that he offers to get certified in using the tourniquet. Ongoing trials, and a lot of these trials are going on in San Antonio at the Center for Intrepid, and that are being funded by the military: osteoarthritis, kidney failure, sarcopenia, low back pain, ACL, rotator cuff repairs, chronic Achilles tendinopathies, fractures, meniscus repairs, and regenerative medicine. There's over 110 references for this talk. If you guys want our reference list, just let me know. I'll email you the reference list. I didn't include it in the handout. And like I said, Johnny Owens is the biggest reference I have. So as of now, I'll open the floor to any questions. Go ahead. So typically, we work up to 2 sets of 15 minutes. We'll do a session of 15 minutes in the first part of rehab and a session of 15 minutes at the end of rehab. So there is plenty of research out there, and because you're only using the tourniquet for 15 minutes, and because these tourniquets are wide, not these narrow ones like Katsu has, these tourniquets are wide, there has been no reported damage to vessels or nerves. And it is because of the size of the tourniquets, the tapering of the tourniquets, the width of the tourniquets. And you're just not cranking it up to an undetermined amount of pressure. You're measuring the pressure via Doppler and then cranking it down 80% for lower extremity and 50% for upper extremity.
You said there's an increase of HGH. Is that coming up on a drug test or anything?
Nope. No, but it's a systemic increase in HGH, but it's still below what they consider positive tests.
What kind of sensation should these athletes be feeling whenever they're doing their...
It's really uncomfortable. It's really uncomfortable. It feels like an incredible burn, like you're doing max workouts. So their legs burn out. They feel heavy. It feels lots of pressure.
I've seen athletes use like the voodoo bands.
Yeah. So voodoo bands is a way to try to mimic this, but there's potential consequences, side effects. You don't know how much you're wrapping on, what the pressure is underneath. So this is a much more scientific approach to me. We athletic trainers, we physical therapists want to be considered elite healthcare professionals. How can we be wrapping a TheraBand around someone's knee or quad or calf at some random pressure and saying that we're legitimate healthcare practitioners when the scientific research says to do it this way? That's the way I look at it. So next question is, how much does a device like this cost? So a device like this costs $5,000, which you say, wow, that's a lot of money. Well, I don't think it's that much money when you, don't tell Butch Farney I said this, but when you walk out there and you see one of his high-end ultrasound stim machines or whatever, and they cost $4,000 or $4,500, I'd rather have this in my training room where I know that scientific research is overwhelming that this is going to produce effects. Overwhelming. So that's just the way I feel about that stuff. So that's a great question. I think over the next couple of years, we're going to see it transfer over to the strength and conditioning world. What? Huh? I would do it on your strength days, right? So when a player squats on his squat days, right, or on his step-ups or lunges, I'd put the tourniquets on. You're going to have to lower the load significantly, so maybe there'll be a benefit on not as many guys blowing out their lumbar spine and blowing out a lumbar disc because they're not putting 450 pounds on their back. They're going to put 150 pounds on their back, 200 pounds, and get the same effect as putting 450 pounds on their back. So I think there's going to be a significant crossover into the strength and conditioning world. I think it's going to be a significant crossover to what I call middle-aged athletes in the pro careers, guys 25 to 30 to 35 that have significant condylar injuries, that have significant low back issues, that can't squat, can't put a load on their back, can't go deep in single leg squats, can't load themselves up because of condylar injuries. They're going to be able to get very similar responses to high intensity training, but with much lower loads. So we're going to save joints and I think save backs.
Have any of your players taken it in the weight room?
One. So what happens is in the world we live in that they're doing a lot of rehab and a lot of strength training in the training room. We do single leg squats, we do step ups, we do lunges, we do all that stuff. We don't have a squat rack in the training room, so we're not doing that. But you know, they'll do single leg squats with 50 pounds, 60 pounds, 70 pounds plus their body weight with the BFR on. We have a functional squat machine in the training room, which is like a horizontal leg press. We have a single leg shuttle that goes up to 450 pounds. So, and we have cable column and a multi-hip where they do standing TKEs. So we'll be able to load them up, no problem, with the BFR on. Any more questions? I know we're running over.
Just to clarify, you talked about doing a rotator cuff rehab with it distally, and then you talked about the knee, but that injury would be, the injury would be more distally and the wrap would be more proximally. How does it make a difference with one cuff you had it here for rotator? You talked about having it on the knee, on the thigh.
So for lower extremity, for anything lower extremity, you always put the cuff as high proximally as we can on the thigh. Okay, for upper extremity, we always put the cuff as high proximally as we can on the humerus. So everything distally you understand, right? That makes sense. So the question is, what happens proximally? So there's this backflow phenomena, and I might have went past it too fast, but there's a research study that talks about proximal gains and how they measured change in cross-sectional area and they measured change in strength in the muscles proximal to the tourniquet. Also, a lot of the HGH changes that you're getting and growth hormone changes, mechanical growth factor changes are happening systemically all over your body. So those are the reasons why we put them where they are and why you're getting effect from the rotator cuff and deltoid and traps proximal to the cuff.
Have they shown gains to, say, if you're doing leg extensions, are they showing gains if the other leg is doing it too?
So it's funny that you say that. I haven't read any research that measured the opposite side, measured cross-sectional area, measured strength. It's always been on the involved side. But we've had a number of players that have said that my involved leg doesn't get nearly as tired as my uninvolved leg. So my uninvolved leg is getting more fatigued now. So we're hypothesizing that it has to do with the increase in cross-sectional area, the increase in the muscle fibers ability, increased protein synthesis, the increased mitochondria and all that stuff. Those muscles are much better trained and more efficient on the BFR side.
Appreciate it. Great job. Great job.
I'm not talking. I'm not presenting.
Hello. Come on, Doc, let's go. We're on time schedule here. So I have the honor of presenting our last speaker. Just in honor or in ways to maximize our time, I'm just going to go ahead and give his titles. Medical Director for the Sugar Land Skeeters, as well as the Medical Director for Sports Medicine at the Memorial Hermann Sugar Land campus. He's the team physician for Fort Bend Christian, as well as several other high schools, and the Medical Director for the U of H Athletic Master's Program. So I'll turn it over to Dr. Rehal Bhojani, and you've got it, and I think everybody's been waiting to hear you. That's why they're still here.
Well, who's left still here, right? All right, I'm going to try to make this as painless as I possibly can. All right, so this year I get the fortunate honor of not talking medical for the first time in 4 years. So I got to do snapping hip, which is kind of nice for me because one of the things that's most commonly underdiagnosed and commonly missed. One of those things that you kind of want to keep an eye out for. So we're going to try to fly through this, and we'll show you all the data and what to look for and what specific tests to go after. In addition, we're going to kind of go through some of the surgical procedures and their effectiveness so that you guys know when to send these guys off and what to expect when you get them back. I have no financial disclosures, even though I have all those titles. Two types of snapping hips. We all know about Cox's Saltines externa, the snapping hip that's along the iliotibial band. There's another one. There's the one that's most commonly missed and usually diagnosed as something else, which is interna, which is snapping hip of the iliopsoas. So we're going to go through both of them. There's 4 other sites for snapping mechanisms in the hip joint. You have the iliotibial band, which we talked about. We talked about the iliopsoas. Those are externa and interna, respectively. You also have the snapping component or the rectus femoris, as well as the biceps femoris and the labrum. So there are multiple places where your hip can quote unquote snap. So it's important to recognize that the snapping story that your patient tells you may not be just from one of those 2 locations. It might be coming from something else. So the physical exam and the story usually gives away the answer for you on this particular problem. We'll go through the interna first, which is the snapping iliopsoas tendon. It's an incidental finding. 10% of the population has it. So that means 10% of the population has it. Less than 50% of that actually believe that they have problems as a result of it, okay? So what's the mechanism? The mechanism is basically going, the iliopsoas tendon going across the anterior femoral, head and capsule at the pectineal eminence. It also can snap in 2 other locations, okay? So it's hard to identify what causes it to happen. Like I said, 10% of the time you find it and you don't even know you have it, and it's just there. When you do injure it, you still don't know how it happened, but it's just going to show itself after repetitive trauma. So painful snapping is what you're looking for. A kid comes to you and an athlete comes to you and says, my hip is snapping, it's in the groin. If it's not painful, usually it's just an incidental finding. But if there's something new and it starts becoming painful, that's when you worry about it, okay? It's either felt or heard during certain activity. It's usually felt inside the hip, okay? You look for the gait changes. You look for that flexed knee and the heel strikes. They're sitting in a position that kind of guards against that snapping hip. And the way you examine it, if you can see the picture carefully, is you bring the hip from the fibula extension and bring it all the way from internal extension with internal rotation, or you can do it the other way. We basically put the hip into resisted flexion at 15 degrees, put them seated, and you just push on the inguinal area and you see if you can get it to snap. You have to be able to reproduce a snap. This is one of those that once you reproduce it, it's your dead giveaway as an answer. This is one that you're not going to miss because they'll be able to tell you that they felt the snap with these 2 maneuvers. Plain films, 0% effective, okay? So if you see a snapping hip, you're not sending a kid to the emergency room. You're not sending the kid to an urgent care. You're not even sending the kid to a family doc because they're gonna get x-rays, and the x-rays 100% of the time are gonna come back normal, okay? There's no evidence of any pathology that shows in snapping hip from an internal standpoint. Ultrasound, you can see it. You have to have a good operator, a good tech, or a good physician that knows how to do it. Usually not the greatest sign. MRI, it's most sensitive, but remember, it's a static study. It's a single frame, and this is a dynamic injury. and you're expecting to get a single frame. So what you're going to look for is certain fluid levels and bursa sac irritations, okay? So when you look at the X-ray or the imaging, you can clearly see that on the right side, you see the iliopsoas tendon, but you look on the left side, you see the red fluid that's completely coming around, more clearly demonstrated right here. That's all you're going to see on MRI for snapping hip. You're not going to see a lot. So it's a story that gives away the answer. It's the exam that gives away the answer, which is why it's important for you guys to recognize that. How do you evaluate it? You have to look at static and dynamic gates. You need to make sure that the mechanics are proper. We've talked about this the last few years. I know there's been a ton of talks in this particular session on gait analysis, okay? Pay attention to your risk factors, the junior recurvatum, the knee flexion contracture, as well as the foot overpronation and the hip flexor contractions, okay? These things are gonna give it away for you. These are your reasons why they get it. What's like I said, if it's an incidental finding, so be it. But if it's an injury, chances are you can fix this. They'll probably not have the pain or just snap on them. And once again, you don't need to really get this fixed. Physical therapy principles, okay? Treat what you see. Treat what you can see based on what you did on the previous slide. Looking at the tightnesses and weaknesses, these are basic principles that you look at. Look at leg length, because leg length is extremely important. That snapping hip is usually due to one side being long compared to the other. Overpronation of the foot, and restore the normal movement, pain goes away. Snapping may not go away, but pain definitely does go away. If all else fails, you just give them a corticosteroid injection directly into the site of maximal tenderness, usually with ultrasound guidance, and you inject the bursa sac. Pain usually goes away. There's your diagnostic injection, okay? You can give them NSAIDs, but if you decide to take them for surgery when they fail everything else, okay, and this is extremely important, your kids do not want to get operated on for this unless they failed everything else. Takes 3 to 4 months to recover, okay? So this is a long-winded procedure to make it go away. Multiple procedure types, basically it's a lengthening procedure. That's all it is. You take the iliopsoas, you make a Z-shaped incision, and you essentially lengthen it so it doesn't snap as well anymore, plus or minus a vasectomy. The data is up there. You have 4 different studies showing 2 different surgical processes. Basically, all we know is that arthroscopic tends to work better. We know that most of the time the pain resolves itself within a few months, that at 5-year intervals that there is still significant resolution of pain and there's no recurrences, and that the people that fail this either A, tend to rehab too poorly or rehab too quickly, or start rehab too quickly in the sense that they get back and they're so quick that the surgery doesn't take well. Same principles you hear for any other surgery, but this is one that's particularly important because once you go in there once, going in there again is a total pain for the surgeons. So this is where you guys as athletic trainers become much more important. Once they get to rehab, allowing them time to rest, allowing that surgical site to heal, allowing the lengthening position to take, then taking the time at the rehab. This is not like a scope of the knee where you can take 6 to 8 weeks and get them back. This takes 3 to 4 months. And it's important for kids to recognize that. So if you have a kid that's in season with this, you might want to try to see if you can hold them off into after season. Doing this during the off season is much more value to you, because chances are if you pull them out during surgery, there's no way you're going to get them back until the next year. Cox's Sultan's externa, the snapping hip, right? This is the one that everyone talks about, the iliotibial band snapping over the greater trochanter and causing irritation of that bursa sac. This is one that's most commonly felt, right? This is the one that you can clearly see, and this is the one that they say, hey, I know something snapping on that side, and I don't know what it is. And it's basically lateral hip plane. It feels like the hip is dislocating or subluxing. That's your giveaway. That's a story giveaway. Some kids will use that word. They say, you know what, I don't feel the snapping. I just feel like my hip's giving out. I feel like it's popping out. Look for that and look for the location that will kind of give it away. It's usually visible, but once again, we have an obese society. So some chances are if you have a big athlete, you may not be able to see it, but you'll be able to reproduce it. And the way you reproduce it is basically check Ober's test and put them on the side and move the hip between flexion and extension. But you got to make sure that you get enough traction and get that hip slightly abducted so that you can get that hip to snap back and forth. If you do too much, it won't snap. If you go too low, you're going to hit the other knee and you won't be able to reproduce the symptom. So it's more of a feel test. And once you feel it, you know what it is. What do you do with it? Once again, plain films kind of story here, right? X-rays, not helpful at all. Zero help at all. Ultrasound, this one's a little easier. For us as physicians, we could do this ultrasound and see the snapping hip, especially right distal to the greater trochanteric bursa, so you can see the hip snapping back and forth. So it's a much easier diagnostic study. MRI only shows fluid in the bursa sac. So this will act like greater trochanteric bursitis, or this will act like IT band syndrome, except with the snapping. So the MRI is almost useless in this regard. The only reason you get the MRI is if we're planning for surgery, just so the surgeon knows what he's getting himself into. And I think I have some pictures. So there it is, the clear fluid sitting in the IT band, and you can see the bursa sac completely inflamed. I did put some surgical pictures up, so you could see they're going in under fluoro. The IT band looks extremely frayed. You can see that it's just damaged down. You can see the trochanteric bursa looks completely worn down and destroyed as a result of repetitive trauma. Once again, same principles, right? This is the snapping hip. We use exact same principles as internal versus external. You look for gait mechanics, you look for genorectorbottom, flexion contractures, you look for foot overpronations, and you look at mechanics and tightness. And guess what? Physical therapy, it's the same thing, except this one, leg length becomes much more important. The longer side is the one that's usually symptomatic. Why is that? Why is it not the shorter side? Because if they're longer, they're standing over like this because the leg has come over, so it actually has a longer longer distance to go. You treat it like IT band. I mean, it's as simple as that. You treat it like IT band, except you work on the lumbopelvic stability also. Okay, that's extremely important because this is a mechanical process that even though you fix the IT band, you get it as loose as you possibly can get it, you get rid of the trochanteric bursa irritation, this thing can still snap. And so stabilizing the entire lumbopelvic region will help significantly as far as long-term outcomes. Once again, steroid injection, this one's easy. This is, we do this all the time. We just inject the treat like a trochanteric bursitis, you calm it down. The problem with this is that this is one that will be a repeat offender. Usually I will give 1 or 2 injections, and after your second injection within a 6-month window, we're going after a different route because it's not working. That means whatever, either therapy is not working, the anti-inflammatories are not working, or they're just not rehabbing right. And at that point, we'll start looking at surgical options. Still same kind of time frame, 2 to 4 months. Same is still kind of procedure. 5 big studies out of the literature that I quoted up here, all involving the Z-plasty lengthening procedure. Basically, the surgeon goes in there, makes a small incision, links up the IT band, may end up taking out the bursa tac depending on how it looks, what we saw in the slides a few days ago. Most people, if not all people, have complete resolution of snapping. More importantly, 99% of people have resolution of pain at the time within 2 weeks of surgery. More than half can return to sports. But the data after sports and recurrence is scarce in the literature. Doesn't necessarily mean it can happen or can recur. I've seen it happen, and I've seen it come back. But more often than not, they just do fine, and you never have to worry about it again. That's it. That's all I got. I did a 15-minute talk in 30 minutes. So you guys are most welcome for that. Questions? So traumatic coxus sultans is very rare in the literature. Usually, if it happens, it's in conjunction with the hip dislocation. It's the only time in the literature it's ever been described. Otherwise, it's always repetitive. It's the chronic overuse with poor flexibility and poor mechanics.
Can it be due to body makeup, like their size?
Oh, yeah.
Like very thin?
Yes, it can. So very thin, extremely hyperflexible joints, certain joints, especially the knee, because you get the flamingo knees, as well as tight bands and tight muscles. And I've seen people with flexion contractures that are just inherent sprinters, for example. I mean, we all know how many sprinters really do stretch every single day. And most of your sprinters are the ones that get all the hip and pelvic pathology as a result of the lack of stretching. So there are some body mechanics that play a role, but more often than not, just repetitive trauma over and over again. No genetic predisposition from what the literature has said. no long-term consequences on bilateral sides. It usually affects one side, doesn't really affect the other side all that often, unless there's a other problem that you're dealing with. Other questions?
You did such a great job. I don't really need this. You did such a great job that you guys don't have questions. So.
Good.
I think David had an announcement to make real quick.